Assalamu alaikum and good morning to everyone. It is really pleasure to start the scientific session of our last day. This last scientific session consists of 5 lectures. One of them is for international foreign speaker, and 4 consist of our local speakers. First of all, I would like to introduce Jing Wing, that is the president of Chinese Society of Nuclear Medicine. He is director of Department of Nuclear Medicine, and he is a vice chief editor of Chinese Journal of Nuclear Medicine, and also the molecular imaging. Dr. Jing Wang focused on the clinical translation of new molecular probes targeted on the tumor for tumor imaging and radionuclide therapy. Dr. Jing Wang successfully hosted over 20 projects, including 2 key projects of the National Natural Science Foundation of China, and published more than 60 scientific papers as the first or corresponding author. I would like to invite Dr. Suhaib on the stage as a chairperson of this session, and Dr. Shazia Fatma as a co-chairperson of this session. Kindly start the presentation of Jing Wing.
Ladies and gentlemen, it's my great honor to be here to introduce the nuclear medicine in China. I'm Dr. Jing Wang. I'm working in the Department of Nuclear Medicine of Xijing Hospital in Xi'an of China. Along this timeline, Chinese nuclear medicine can be traced back to the 50s of last century. In 1956, Professor Wang Shizhen initiated the Chinese nuclear medicine. The Chinese Society of Nuclear Medicine, CSNM, was founded in 1980, and the Journal of Chinese Nuclear Medicine was first printed on next year. The first imported SPECT was installed in 1983. Since then, the nuclear medicine in China developed rapidly. Here now, the CSNM has gone through the 11 sessions. There are the pictures of 12 presidents. I'm the last one, CSNM president right now. All the former presidents have made great contribution to the development of Chinese nuclear medicine. The regular term of service is 3 years now. The committee of the CSNM included 63 members, a president, a former president, and the president-elect, 4 vice presidents, as well as 21 standing members. Under the management of the committee, Young's Committee and 11 groups were set up, including cardiology, oncology, neurology, radiopharmacology, and so on. The committee of CSNM has its own website to introduce the development of nuclear medicine and the update news. Welcome to visit our website to know more about us. In order to have a great contribution to the diagnosis and the treatment of related diseases, CSNM, together with other Society of Chinese Medical Association, have formulated nearly 30 criteria, guidelines, and expert consensus. In 2020, the CSNM conducted a national survey of nuclear medicine, covering 31 provinces of China. This is the number of nuclear medicine departments in China in the past 30 years. As of 2019, there are currently 1,148 nuclear medicine departments nationwide. There are currently 427 positron devices, including PET-CT and PET-MR, and 903 single-photon devices, including SPECT and SPECT-CT, across the country. While in 1989, 30 years ago, the number of positron equipment and single-photon equipment was 0 and 44 units, respectively. Chinese nuclear medicine has made great progress in the past 30 years. This is the distribution of positron equipment in the country. It can be seen that the provinces and cities in the southeast coast have the largest. This is related to the level of local economic development, and the level of economic development in these areas is also the highest. Among them, there are 44 units in Guangdong provinces, 35 units in Beijing and Shanghai, respectively. In 2019, there were 120 medical cyclotrons nationwide. They were deployed in 117 medical units. In 2019, there are a total of 41 small animal PET, SPECT, MR, CT, and other equipment in the country. This is the workload of nuclear medicine investigation across the country. In 2019, approximately 2.51 million people underwent SPECT examinations, and 860,000 people underwent PET and PET-MR examinations, both of which are significantly higher than in 2017. The patients undergoing PET-CT examinations were mainly tumor patients, accounting for 97%. The rest were neurologic, cardiovascular, and bone imaging. Similar to PET-CT, patients undergoing PET-MR examinations are mainly tumor patients, accounting for 87.4%, but there are also a certain proportion of patients with neurological and cardiovascular diseases. This is the SPECT imaging situation, mainly bone imaging, accounting for 63%. The endocrine system and the urine system accounting for 16% and 12%, respectively, while the cardiovascular system accounting for only 4%. There are 770 nuclear medicine departments nationwide that carry out radionuclide therapy, and there are 2,544 radionuclide therapy beds, mainly for the treatment of thyroid diseases and bone metastasis. In 2019, 145,000 hypothyroidism patients and 84,000 thyroid cancer patients received iodine-131 treatment. 89 strong-tier treated 10,000 bone metastasis. According to the data up to 2019, there were about 12,500 people engaged in nuclear medicine-related work in the country, including 5,400 doctors, 3,700 technicians, 2,600 nurses, and 210 radiochemists. China has started to develop its own nuclear medicine equipment in early 1960. Scanner and gamma camera were made in 1970s, and the first domestic PET was produced in 1990s. In the past 10 years, Chinese nuclear medicine equipment manufacturing has developed rapidly. About 6 manufacturers could produce PET-CT devices. The first domestic SPECT with double detectors has been approved by National Medical Products Administration (NMPA) in 2017. The PET-MR is already merchandised. This slide shows the status of radiopharmaceuticals in China. 12 radiopharmaceuticals for PET imaging, 15 for SPECT imaging, and 12 for radionuclide therapy have been approved by NMPA and used in routine clinics. Currently, there are 34 radiopharmaceuticals approved by CDE for clinical trials, including 7 for SPECT, 12 for PET, and 11 for radionuclide therapy. According to the type of diseases, 44% of radiopharmaceuticals is for tumor diagnosis, 41% for radionuclide therapy, and 15% for CNS diagnosis. 40 GMP qualified centers were established to produce radiopharmaceuticals. Our National Radiopharmaceuticals Delivery Network, which covers 20 provinces, has been set up to supply the radiopharmaceuticals for clinical service. In order to promote the development of nuclear medicine, national and local academic activities have been held annually. Each year, CSNM organized 7 national conferences. This slide shows the national conferences of nuclear medicine from 2017 to 2023 that were held in different cities in China. Over 2,000 delegates attend these conferences every year. We warmly welcome all of you to join us in the future. CSNM also pays special attention on the international academic exchange. As early as the 1970s, Professor Wagner came to China to teaching cardionuclear stethoscope technology. In the past, many Chinese nuclear medicine colleagues have participated in international academic conferences, including SNMMI, EANM, and so on. As a highlight country, in 2018 SNMMI, about 200 delegates attend this meeting. During 2023 EANM, we visited IAEA and had a talk with the Deputy Director General Najata. In 2021, an official document was jointly issued by 8 ministries. The document defines the targets and guidelines for nuclear medicine in the future, including research and development of radionuclide devices, and the radiopharmaceuticals, as well as the training of human resources. A target has been set to establish one nuclear medicine department in every country of China and in every tertiary hospital by 2035. Next year, the annual National Conference of Chinese Society of Nuclear Medicine will be held in Zhengzhou, Henan Province, in September 19 to 22. Welcome to China. Thank you for your listening. Have a nice day. Thanks.
Presently heading the Department of Nuclear Medicine. He is a former VP of the PSNM. He has 18 publications in various national and international journals. Kindly, I invite Dr. Basit Iqbal to kindly start his presentation about the role of SPECT-CT iodine 131 imaging in thyroid cancer. Dr. Basit.
Thank you very much, Dr. Azra. For the past 2 days, all we've been hearing is hybrid imaging. So the hybrid imaging indeed is taking over. And one day, due to redundancies and the fact that nobody will be making non-hybrid imaging cameras, we'll all be doing everything on a hybrid imaging camera. So right now, we need to find the new indications that are there. So with PET, every day we're finding new indications for its usage in oncology. Similarly, for SPECT-CT, because it's a new technology, every day we are discovering what we can do with it better than what we were able to do with the previous non-hybrid imaging technologies. So one of the fields that one of the fields that the hybrid imaging or SPECT-CT can help is the I-131 imaging. Why? Because I-131 has high energy gamma emissions, and it doesn't give you very good sharp images. So adding CT to it does help in a fair bit, especially in when we're trying to stage the disease, follow up recurrences, and so on and so forth. So first, just a slide to say what's the scale of the problem. We are an iodine deficient country, high incidence of goiters, solitary nodules, cancers. 80 guidelines, the latest ones, very controversial. However, that's the best that we have at this point in time. What does it say about surgeries? It says more than 4 centimeter do near total thyroidectomy followed by radioactive iodine. Less than 1 centimeter, just go with lobectomy, no radioactive iodine. But it's the middle part where there's a bit of a problem, where if it is between 1 and 4 centimeters, when do we go for near total, when do we do lobectomy, and when do we give radioactive iodine? And this is where SPECT-CT can actually help us a lot. Excuse me. When we search the literature, latest literature that has been published, it says that we can use SPECT-CT in differentiated thyroid cancers in localization of nodules, pre-treatment planning, post-treatment assessment, lymph node evaluation, which is very important, evaluation of distant metastasis, because we can sometimes have physiological uptake, and it's really hard to differentiate between the two. We can measure the response to treatment, and we can do recurrence assessment, and I'll show a few images in regards to most of these things. Post-surgically, we do frequently do a low dose iodine 131 image, and SPECT-CT when for that imaging can help us a lot. Why? It can be useful for the assessment of residual thyroid in the thyroid bed and the completion of staging by visualization of lymph nodes in any, or detection of presence of distant metastasis and its differentiation from physiological excretion. So that place between 1 and 4 centimeters, you want to know whether it's high risk or not. You want to go for total thyroidectomy and then radioactive iodine or not, and then it can lead to accurate therapeutic dose planning. Yesterday we heard a lecture where they said that to a child with large disease, they had given a low dose of 66 mCi, and that child is still having a bit of a problem. So looking at a typical case, this is a patient with 62-year-old female with papillary carcinoma, follicular variant, total thyroidectomy, no lymph nodes were involved, whole body scan was performed under hormonal withdrawal. And we can see that there are 3 areas of uptake that we can see. There is a very subtle focus in the middle. Let me see if I can point the laser pointer to it. Sorry. So is this, what is this? Is this just something that we are seeing? Very low uptake. Does it have any significance? And so in this patient, a SPECT-CT was performed, and we can see that it is a mediastinal lymph node. So it's not just something in the esophagus. It is actually a lymph node. So again, state changes, treatment changes, prognosis changes, so on and so forth. Another patient, 37-year-old female, CA thyroid, very low level of thyroglobulin, but very high anti-thyroglobulin antibodies. So not an ideal situation. We need to do some imaging. So imaging was performed, and if you look at the planar image, we can see that there are 3 foci, 1, 2, and 3. This is somewhere in the face, so probably not very malignant, but still we need to have a look in the neck and then lower down. So first the top activity, SPECT-CT was performed, and it's in the nasolacrimal duct, so it's just a normal physiological finding. It's not metastasis. The second one, tip of the hyoid bone, and at the tip of the hyoid bone this was a remnant of the duct remnant, the thyroglossal cyst remnant. So again, physiological, not metastasis. However, when a SPECT-CT of this last one was done, it is a lymph node. So it's a remnant, sorry. You can see the clips down there. Surgical clips, this is just the remnant. So no distant metastasis. So without the help of SPECT-CT, we would have been in a bind whether this is this is metastatic disease or not. But with the help of SPECT-CT, now we can say no, there is no distant metastasis. Patient is relatively safe and downstaged. Similarly, another similar patient, 36-year-old female, multifocal papillary thyroid cancer, thyroglobulin very low, but anti-thyroglobulin antibodies quite high, so not very reliable. 2 foci when it comes to the uptake. SPECT-CT is performed, and as you can see, with this here, these are the surgical clips. So this is probably a part of the remnant. However, this uptake is in the lymph nodes. So the stage changes, treatment changes, dose changes. Young child, 14-year-old girl, post-thyroidectomy treatment, 1 MCI scan was done, and you can see there is a lot of uptake. And where is that uptake? It's in the lymph nodes. So we can see it's in the lymph nodes. Bulky disease, resurgery is needed. Patient cannot proceed without resurgery, and till then any amount of radioactive iodine will not help the patient. Again, a diagnostic scan for 37-year-old female after total thyroidectomy. Want to see a lot of uptake. Is it just the thyroid bed, or is lymph node involved. And if we look at the lower panel, we can see that there is some lymph node involvement. In the post-therapeutic RI whole body imaging, when we've given a rather large dose, how can SPECT-CT help us? We can do whole body scan using, it can do the completion of staging, it can do risk stratification, assessment of residual disease, and for future therapeutic planning. Again, a patient in which radioactive iodine has been given, 3.86 gigabecquerel, and if we look at the SPECT-CT, we can see that it is a lymph node. So here it just looks like the bed, but when SPECT-CT is performed, we can actually see a lymph nodes involved, state changes. I should be able to wrap it up within the next 2 minutes. Similarly, this is a patient in which a rib resection, a rib mass was seen, rib resection was done, turned out to be thyroid cancer, underwent total thyroidectomy, and a large dose was delivered. And when the scan was performed, we can see uptake in the abdomen and in the shoulder. The shoulder uptake turns out to be in the scapula, if you look here, and then abdominal also uptake is also deposits of CA thyroid, and now needs a much larger dose when it comes to further treatment. Again, a patient in which radioactive iodine is given, no focus in the neck as such, nothing in the chest. However, when SPECT-CT was performed, it found out that rather large lymph nodes which are non-iodine avid are there, and now this patient probably needs to undergo PET scan and then TKIs and so on and so forth. In the normal follow-up protocol for us when it comes to CA thyroid is we do serum thyroglobulin and anti-thyroglobulin antibodies, and thyroglobulin measurement can be affected by the presence of anti-thyroglobulin antibodies and cause inaccurate results, and then we have to do whole body iodine scans. So in this patient, 47-year-old female, high thyroglobulin levels 11 years after successful treatment with total thyroidectomy and radioactive iodine. Whole body scan has been performed, and it turns out that there is a lymph node there, and then this patient now has recurrent disease and then now needs more radioactive iodine and treatment, so on and so forth. So thank you very much. If there are any questions, I'll be more than happy to answer them.
Is there any question from audience? Especially from the students or residents?
Please. Yes, you're right. Because of the fact that radioactive iodine has some gamma radiation that's very high, probably even the heaviest collimator will not be able to help us. But because of the fact that we get good localization, it's not improving the resolution of the iodine part of it. It's what it is doing is giving us better localization with the CT, and that tends to help with the up or down staging. So per se at this point in time, I don't think there's very many things that can be done to improve the resolution of the iodine scan, but with that localization we can maybe get better results that way. Right, thank you very much.
Thank you, Dr. Basit, for such a nice talk. Now I would like to switch over to next talk, that is about the thyroid cancer management and comparison of guidelines. It will be presented by Dr. Adnan Saeed. Few words about the Dr. Muhammad Adnan Saeed. He is working at Atomic Energy Commission Hospital, Noori, as a consultant nuclear medicine and also serving as a head of Department of Nuclear Medicine and Allied Division. He is examiner and supervisor of FCPS, MPhil, MD, and PhD students of different universities. He has almost 24 national and international publications as a first author. He served as a General Secretary of Society of Nuclear Medicine from 2019 to 2021. He is a technical expert and auditor of ISO in health sector and also recipient of General Bukhari FCPS Gold Medal in 2009, Performance Gold Medal, Pakistan Atomic Energy Commission in 2016. Now I would like to invite Dr. Adnan to tell us about the thyroid cancer management and also the comparison of different guidelines. Dr. Adnan.
Bismillahirrahmanirrahim. Assalamu alaikum and very good morning. First of all, I will congratulate the organizers of this conference for the last 2 days, very good sessions, and the attendance of the conference is also very good. And I'm also thankful that they have invited me on this occasion. The topic which is assigned is a bit lengthy, but actually such topics are discussed in the conferences just to give an idea about the importance of that thing, and later on the students and the other practicing physicians, they learn from their own experience and they consult these guidelines and other things for the management of the patients. And differentiated CA thyroid is the first of the thing which is being managed in our department if we consider the therapeutic part of the nuclear medicine. So as I have been given the 15 minutes, I'll try to wrap up the things within the given time, and because in that small time the guidelines cannot be compared at a whole, so I'll focus on 2 main points for these things. The layout is a very 1 or 2 slides regarding the statistics of the differentiated CA thyroid and risk assessment. Then regarding the guidelines, I'll focus on the surgery and the radioactive iodine, and just only 1 slide for the use of the TKI, as it will be dealt later on by another speaker of this session. So this is a slide regarding the statistics, that the 5-year survival of differentiated CA thyroid is 98.5%, and also the prevalence of the disease among the other cancers relating to the incidence, mortality and prevalence. Regarding the guidelines, the known the guidelines or the criteria which we are following started from the ATA, and then it goes on. The latest one is the NCCN, which is published in August 2023. So in most of our centers we are following ATA, but as new changes are being taken, then I will compare few of the things of the ATA, and the latest one is the NCCN of August 2023. The things which we will discuss, the post-operative risk stratification, and this involve the different risk groups that have been defined in the ATA guideline. Then surgery and post-surgery evaluation, it depends on the tumor size versus risk, as in the previous one, the low, intermediate, high. Then type of the surgery which is being carried out depends on the initial diagnosis before the surgery, or if it has been diagnosed after the surgery, then the post-surgery evaluation. The radioactive therapy depends on the initial ablation which is required in which cases, and stratification as per risk category and type of the surgery. As per ATA guidelines, there are low risk, intermediate risk and high risk categories. In low risk category with papillary CA thyroid, there are no local or distant metastasis, and all tumor has been resected. There is no locorenal invasion, and tumor is not of any type of aggressive histology. And if iodine 131 is given in such patients, there are no avid metastatic foci outside the thyroid bed, and there is no vascular invasion. Whereas in the intermediate risk, there is microscopic invasion into the parathyroidal soft tissue, and metastatic foci are observed in the first post-treatment whole body scan. They may have aggressive histology, and clinically N1 or more than 5 or pathological N1 with all involved lymph nodes. Where in the high risk group, There is macroscopic invasion of the tumor. There is incomplete tumor resection. Patient have distant metastasis and pathologic N1 with any metastatic lymph node and follicular thyroid cancer with extensive vascular invasion. However, in the NCCN, they use this staging, which is proposed in the TNM staging of differentiated C thyroid and anaplastic carcinoma 2017. According to that, under the age 55 years, there is stage 1, which is dependent on stage 1 and 2, depending on the metastasis only. Whereas on 55 years and older, they are stage 1, 2, 3. We are practicing these stages, and these are dependent upon the T1 and N and M status of the patient. Regarding the surgical management, as far as this this NCCN guideline is concerned, if in cases of the papillary CA thyroid, if the diagnosis is confirmed before the surgery, that is FNA is showing the papillary carcinoma or suspicious for papillary carcinoma, then depending on the size, if the size is more than 1 centimeter, then the carrying on the other investigations and all the things, the latest recommendation they have said that the total thyroidectomy should be carried out. However, they said if there is otherwise low risk pathology, that is written in the footnote, then lobectomy without completion may be an appropriate option. Similarly, if it is less than 1 centimeter, then as we know that same as previously we are following, then different parameters for the risk assessment will be carried out, and the lobectomy will be sufficient in such cases. Whereas if a patient has got on FNA, follicular neoplasm, and the Bethesda category 4, even in such cases, the total thyroidectomy is carried out if there is radiographic evidence of the extrathyroidal extension, or perioperatively it is found that there is extrathyroidal extension. In previously, it was said that it is if tumor size is more than 4 centimeter, then total, but this has been removed from the recent one, and the lobectomy or stomectomy, this is reserved for such cases in which there is it is encapsulated or and also the angio invasion is not seen. If in cases of the oncocytic carcinoma, the FNAC, it comes on the FNAC, even in such cases, the main treatment of the surgery is the total thyroidectomy. In cases of the papillary CA thyroid, this is post-lobectomy. If a patient has got diagnosis of the papillary CA thyroid after the surgery, then if nodal metastases are confirmed, then the completion of thyroidectomy is required. Previously, in this group, the poorly differentiated was also placed in this, that any one of the following is present. But now, in cases of the post-lobectomy, the poorly differentiated is placed in this arm, and even in these cases, completion thyroidectomy is recommended. However, in a few cases, if there is disease is around 1 centimeter, disease monitoring can be carried out. In ATA guidelines, they have clear recommendations regarding if malignant cytology is present or there is suspicions of the malignancy, then the surgery is carried out, and total thyroidectomy if along with the suspicion there are certain other factors like clinical risk factors, sonographic features, and possible results for mutational testing. And if there are cases who are cytologically indeterminate nodules on FNAC, in such cases when surgery is considered, then the recommendation initial recommendation is the lobectomy, followed by the findings on the histopathological sample. However, in the cases of the increased risk for malignancy, total thyroidectomy may be preferred in patients with indeterminate nodules that are cytologically suspicious for malignancy, positive for known mutations, specific for the carcinoma, or larger than 4 centimeter in size. One of the recommendations that explain many of the things regarding the surgery in the ATA is that the completion thyroidectomy should be performed to patients for whom a bilateral thyroidectomy would have been recommended had the diagnosis been available before the initial surgery. And regarding the central lymph node dissection, that should be included if the lymph nodes are clinically involved. And thyroid lobectomy alone may be sufficient treatment for the low-risk papillary and follicular carcinomas. Then the post-surgical evaluation. When if there is no gross residual disease, then the consideration, then the patient will be assessed for the risk assessment and for the other factors. However, a patient has got gross residual disease, then it will be divided into further segments depending on the resectable or non-resectable. Whatever the arm it is, we see that in all cases we proceed for the radioactive presence or absence of the radioactive iodine uptake. And then most of the cases, radioactive iodine can be given even if it is absent in the presence of the gross residual disease. In ATA guidelines regarding the decision for the radioactive iodine treatment, this assessment is done after the surgery. If in a case of the low risk DTC, the total thyroidectomy have already been carried out, in such cases, a post-operatively evaluation is done in which there is serum TG levels, diagnostic RAS scanning, ultrasound and other imagings are carried out, and if there is remnant radioactive iodine ablation is not routinely recommended in these cases. However, they have said that if in some center or certain reason it is required, the dose may be 30 millicurie is sufficient for such cases. Whereas in low risk DT cases, if less than total thyroidectomy has already been done, then same evaluation will be carried out, and if these according to these parameters, even in these cases radioactive remnant ablation is not recommended. Then we come to the intermediate risk, and if total thyroidectomy has already been carried out, again the post-operative assessment will be carried out, and on the basis of this, for the remnant ablation, 30 millicurie is generally favored over higher administered activities, and for adjuvant therapy, administered activities above remnant ablation up to 150 millicurie are generally recommended. In cases of the high risk DTC, if total thyroidectomy has carried out and there is no gross residual disease, then after the post-operative evaluation, radioactive iodine should be considered and certain recommendations for the dose of the patients. In NCCN for the radioactive iodine treatment, previously if there is the tumor size that is radioactive iodine is not typically recommended. There are three parts. Radioactive iodine is not typically recommended. Other is the radioactive iodine selectively recommended, and the last is the radioactive iodine typically not recommended, or if any of these present. So number one is not typically recommended. We can see that if it is classical papillary thyroid and the largest primary tumor is less than 2 centimeter, and also the stimulated TG is less than 2 nanogram per ml. This has been added in these recent guidelines, and in case of the cases in which it is typically recommended, the addition is the significant N1B disease and vascular invasion and bulky or more than 5 positive lymph nodes. Whereas in cases in which selectively recommended, there are certain features on the basis of which we will divide it into two parts, that it is not required in patients with classical papillary C thyroid who have T1B and T2 disease, and it is recommended when the combination of individual clinical factors such as extent of the primary tumor, histology, degree of lymphatic invasion, and lymph node metastasis, etc. are present. When we compare the NCCN of 2022 with 2023, there are certain features which have been added in the same groups, that is not typically recommended and recommended. In 2022, in cases of there is a post-operative unstimulated TG. If it is less than 1 nanogram per ml, then it is not recommended. However, they have added the post-operative unstimulated, the same value, or the stimulated TG less than 2 nanogram ml. And in case of this iodine typically recommended, the last one, they have included the significant N1B disease in the newer version and the vascular invasion. Whereas in the middle group, the detectable anti-TG antibodies, this is not present in the recent guidelines, and the post-operative unstimulated TG, the value has been given, that is TG 1 to 10 nanogram per ml. This is the some principles for the radiation and radioactive iodine therapy in these guidelines, in which there are certain doses which have been recommended, that they said that for the remnant ablation, which we have discussed in the previous slides, where remnant ablation is indicated, then 30 to 50 millicurie is sufficient according to these. But there are certain factors, and depending on the different parameters, this can be tailored. The adjuvant therapy, which is 50 to 150 millicurie, this is for higher likelihood of residual disease based on operative pathology or pre-therapy radioiodine scan. Whereas for the treatment of the known disease, the 100 to 200 millicurie is recommended for the proven unresectable or metastatic disease based on pathology or pre-therapy radioiodine scan. In special circumstances, they have mentioned about the pediatric groups and certain other factors. These special circumstances are treating the CNS metastasis and other factors. These are also discussed in these slides. अभी आखिरी आपने मुझे बताया था 2 मिनट अच्छा iodine last 2 slides. I was waiting that you will tell me this. Iodine 131 therapy is not indicated in all cases of DTC. In low risk patients, low dose iodine 131 therapy does not increase the risk of recurrence. Iodine 131 dose must be titrated according to the risk stratification and indication. Strong TSH suppression is not required in all cases during the follow-up. And during follow-up, iodine 131 whole body scan is not mandatory in all cases. And just one slide for that, as I have told that about TKI, that NCCN and the ATA guidelines are more or less same, that it is recommended for the radioiodine refractory and certain other factors. Dr. Asghar will talk about it in detail. So in short, all these guidelines, starting from the ATA, this ETA, ESMO, and this NCCN, they all are targeted for the management of the thyroid cancer patients effectively. And we all are learning these things and practicing for the better health and better outcome of the patients. Thank you very much for the patient listening.
Assalamualaikum. My name is Dr. Ijaz from Peenam Cancer Hospital, Faisalabad. So one of your slides mentioned about the mutational testing. My question is, do you do mutational testing in your clinical practice? If yes, then what testing and when?
In our clinical practice, in our setup, we have limited testing of BRAF only right now. Previously, we have done few cases of TERT mutation, but right now only BRAF we are doing, but that is also not in routine. So this is due to certain reasons like infrastructure and also the cost. But in the last month, low risk pathology, I have done I think probably 3 or 4 cases in which one was positive and other was negative for that.
Thank you, sir.
Thank you, Dr. Adnan, for enlightening all of us about the practical approaches and guidelines that would be effective not only for our students and residents, but also for all of us. It is really a great honor for us to have Dr. Muhammad Babar Imran with us as a speaker. Dr. Muhammad Babar Imran is acting as a director of Peenam Cancer Hospital, Faisalabad. He is chief editor of European Journal of Medical Case Report and also the chief editor of Pakistan Journal of Nuclear Medicine. He is examiner and supervisor of postgraduate trainees of nuclear medicine, including FCPS, MSc, and PhD. He is examiner of Asian Board of Nuclear Medicine and has a strong research competency proved by high-quality papers published in peer-reviewed renowned journals of high international ranking. He has an honor of national and international prestigious awards. Now, I would like to invite Dr. Muhammad Babar Imran about his talk of the management of thyroid cancer, a doable model of theranostics. Dr. Babar.
Bismillahir Rahmanir Rahim. Assalamu alaikum and very good morning. Thank you very much. The organizers have given me a chance to talk about thyroid cancer. Dr. Shazia and team has done marvelous job during this organization of the conference. Many new things have been introduced in this conference, and one of them might not be noted by probably all of you. जैसे वो in Urdu जैसे वो कहते हैं महफिल के बाद लंगर भी तकसीम होगा. We have written award and dinner भी दिया जाएगा. So this was new for this conference. It is written in the banner that we will provide you dinner as well. Anyway, I'll be talking about thyroid cancer from a little bit different perspective. It's 9 common cancer, most prevalent in females. And lifetime risk is something like 1.2%. We do get these kind of cases where the disease is relatively advanced, or neglected patient where disease has advanced. But majority or many of the cases would be in low risk category if we have proper diagnostic facilities or proper screening facilities available to our community. And since there is mixture of low and high risk patients coming to us, one size should not and does not fit for all. And we need to segregate patients as per their risk so that we can provide proper, appropriate, optimal treatment to each group and each patient. Suppose this is a patient, this is in low group, low risk group, and conventionally if we are, say for example, working and practicing in 90s, then the conventional treatment would be surgery followed by iodine ablation and then supplementation with thyroxine. But in the present time, present era, something new has emerged, and that is simple observation, active surveillance. And that is the glory of medicine, to constantly move forward under the light of our experience and learning. This is a paper published in 2023, originated from Japan, published in Thyroid, in which they included 4,635 patients from low risk group. They segregated in 2 groups. One was active surveillance and other was immediate surgery. 62.5% patients were in active surveillance and rest of the around 38% patients in immediate surgery. Patients were followed for next 15 years during the study. Not all of them, but the study carried out was over a period of 15 years. And 242 patients out of active surveillance group, they need to go for the surgery due to certain definite indication already in the protocol of the institute. Now when we compare this active group and the surgery group, incidence, untoward incidence over a period of 15 years, in both groups this was almost equivalent. There was no difference. So active surveillance or the surgery, they proved almost similar with reference to incidence of any untoward event. Now if we compare the group of 242 patients which needed surgery later on during the follow-up, there was no significant difference between the clinical characteristics of this group with reference to the other group which had surgery immediately in right away at the beginning of the study. Now if we compare any untoward effect of this surgery, again there is no difference. If you see the last column, there is no difference in the probability. There is no difference between these two groups. Now, I'll come back to this slide again later on. When we decide for surgery, whether we need to go for lobectomy or total thyroidectomy, then cumulative risk of death due to thyroid cancer, there is no significant difference between these two groups. If we opt for thyroidectomy or the total thyroidectomy or the lobectomy. When we zoom this here, when we zoom this line, again, there is no difference. These two lines of the two groups, they are exactly following the similar path. Now, preference or shifting of partial or the lobectomy to total thyroidectomy, or getting the patients for total thyroidectomy, this decision is not only done by the surgeon on surgical floor, but this is influenced by nuclear medicine physicians as well. How? If we want to ablate each and every patient coming to our department, then probably we will ask surgeons to go for total thyroidectomy to ease out our life, to ease out our job, expected job to ablate. Now, why we decide like that? That is based on the risk of persistence of disease or the recurrence of the disease during follow-up. And these all characteristics are of low risk group, right? Low risk group. And here, in this case, all of these subjects were low risk group, except here 242 patients, which were later on shifted because they actually posed some problem and they actually were not going like as a low risk, so they needed to go for the surgery. Can we define how these 242 or this kind of patients can be segregated right in the beginning when they come to nuclear medicine department or come to the surgical floor, that these cases are of high risk or not low risk, at least they have substantial risk, and then we need to be more careful for the decision? Yes, there is one thing, and that is genetic analysis, BRAF V600E. In low risk patient, as already told, and it will be repeated many times, anywhere you go to the conference where thyroid is being discussed, that it is not recommended in each and every patient. Radioiodine therapy is not recommended in each and every patient, especially when we talk about low risk. Of course, it is recommended in high risk patient. Then comes for the dose. There was a study in France. I just quickly go through this study. This study was performed in 24 centers in France, and at the end of the study, they concluded over a period of median follow-up of 5.4 years, there was no difference between low dose and high dose for the ablation of the group. Now, again, as I said, that I'll bring you back to this slide. Here, if you see, there is comparison of active surveillance group. Am I visible? Yes. Active surveillance group and then immediate surgery group. But here what author has done, something very clever. It has compared not 242 patients, rather whole patient group. So N is different. So when you bring this N, 2,896 in active surveillance group and 1,739 subjects in immediate surgery group, then p-value is not significant. But if you bring up here 242 subjects, N is here, and then immediate surgery is 1,739, then p-value changes. So actually there was difference between presence of lymph nodes. There was some trend of hypoparathyroidism and laryngeal nerve injury. Can we, right in the beginning, as I pose a question, can we stratify among the low risk patient that these are the patient group where we need to be more cautious, where we need to be more careful? Yes, through probably mutation analysis, genome analysis. If BRAF V600E is positive, if TERT mutation is positive, or the combo is positive, then risk of malignancy in a sample, even if the FNSE is giving us negative result, still a risk of malignancy is 100%. Recurrence. If we have done some sort of treatment and BRAF positivity and negativity, it brings lot of difference. Recurrence will be less than 10% if BRAF is negative, and it will be more than 25% if BRAF is positive. Similarly, combo BRAF and TERT, if both of these are negative in a sample, then recurrence rate is less than 9%, and if these are present in combo, the recurrence reaches something like 70% of the cases. TERT promoter mutation, again, it indicates aggressive behavior. If we see from benign to anaplastic carcinoma, the prevalence of TERT ranges from 0% to 40%. Overall survival. After the treatment, if TERT promoter mutation is absent, then overall survival reaches more than 98%. If this is positive in PTC, then survival reduces from 95-98% to only 75%, 10-year survival. And if TERT promoter mutation is positive in differentiated thyroid cancer as a whole, a group, then 10-year survival is something like 66%. Then our love child, radioiodine. Its avidity, loss of avidity, this is very important for nuclear physician. Since the loss of avidity, we need to send this patient to some other modality because now ab hamare haath khade hain, we can't do anything. A loss of avidity in BRAF positive alone, it's in 70% of the cases. And if BRAF and TERT mutation in combo is positive, then loss of avidity over the years will be something like 97 to 100% of the cases. When we put all this data to AI generates nomogram, and that tells us that the chances of having lung metastasis if BRAF is positive are strong. This is one of the strong indicators that lung metastasis will appear during the follow-up. BRAF positivity and flip-flop phenomena with reference to uptake of iodine and FDG. In the thyroid bed, uptake of iodine is more. In the metastasis, uptake of FDG is more, and this is not very good indicator for the patient survival, patient recurrence. If BRAF is positive, this phenomena is seen in lymph nodes, lungs, and bone metastasis. So, if BRAF is positive, if mutations are positive, we need to be very careful, and we can shift patient, or we can think to shift patient from active surveillance to active management, from conservative surgery to relatively wide bore firing from the surgeon. Yes, I'm going to finish. You need not to say. There are many things to discuss with reference to mutation, and you will probably learn in many, you will listen in many conferences and gathering. All these are there, and just for the sake of short time, I'm taking you to the take-home notes. As it is already said, surgery is not recommended in every case. Radioiodine is not recommended in every case. But incorporation of genetic analysis in our practice probably will assist us in proper, feasible, appropriate decisions. However, it is only applicable if doctor understands, if patient understands, and if, very important, environment is feasible, environment favors compliance. Thank you very much. Any question?
Is there any question from the audience?
Yes. Yes. It will be something like 25,000, 25 to 60,000, but we will try to make it as cost acceptable as much possible, yes.
And I think it's being done in very few centers at the moment.
Yeah, but we will start from BREF right in the beginning, and then we will shift to onward, because we have infrastructure and we have proper trained manpower for doing these things.
Can we go back to your slide where you showed the ultrasound image?
मर गए भाई.
नहीं.
पंजाबी कहते हैं फड़े गए, वो भी उस्तादों
वापस
के
जाइए,
हाथों
वापस
फड़े गए.
जाइए.
जी.
हाँ. इसका क्या बनाया? You diagnosed it in 1990 and then you went on.
No, I didn't say.
Okay, so what does this mean?
What I said, that if we are practicing in 1990, 1990 में अगर हम बैठे हों, जब मैं स्टूडेंट था, आप हमारे उस्ताद थे, then most of the cases were going through surgery and then radioiodine ablation and then levothyroxine. But at present, when we are in 2023, one new thing has emerged, and that is simple observation.
Yeah, but this patient, I would be very scared about this particular patient because it's posteriorly located and it is bulging beyond the thyroid capsule. So I really don't know if I would be cavalier about this particular patient or send him to surgery. I would be very scared about this.
Thank you very much. As experts, knowledges, your opinion is always prime. But I was just explaining, if you have these kind of low-risk patients, then one of the option is observation. I didn't decide that we go for observation. Actually, this was a starting point to start my story. मैं अपनी गज़ल बनाने के लिए एक start करना था. जी.
Sir, एक छोटा सा सवाल है कि now, so this is the last question. As you said, that if you don't do surgery in all those cases which are T1 and over 15 years, if you don't do surgery, the untoward effects are minimum and they are comparable to the group which has received surgery immediately.
I didn't say that. It is published. I started my question from here.
It's published.
Yeah.
What was the impact on the T? Like the T has not to be constant for 15 years if it is malignant. It has to grow over the period of time over 15 years. And say at a certain point, it has to become T2 or T3 in 15 years. Was it mentioned like then your decision making would change, whether this will be reassessed, and definitely if it is malignant, it has to grow. Otherwise your diagnosis would be questioned.
No, not necessarily. If it was malignant, not necessarily that it has to grow very fast.
Not very fast, but
yeah. That is why two things I have said. That you need to be careful, one. Number two, can you predict at any time that this is the group that we need to be more cautious to? And third thing is that the last slide, when I say take home message, when environment is compliant. Environment compliant means that we can have proper surveillance for this patient. So that's why these things are actually integrated. Yes, any more comments, questions? Thank you very much.
ये मैंने माइक लिया अपनी बारी.
Thank you, Dr. Babar. I really appreciate you how well you explained the concepts about the management of thyroid cancer. Actually, this topic is such a vast topic that every one of us has many queries, but I cannot allow this session to expand more. This is the time of our last presentation, but before announcing about the last presentation, I would have an announcement for all the oral free paper presenters. There is a parallel session for the oral free presentations. Kindly, all of you who have to present their oral free papers, kindly join in the exhibition hall. Few words about the Dr. Asghar. Dr. Asghar Hussain is a consultant oncologist working at Kiran Hospital, Karachi. He is a true hybrid physician. Since he joined as nuclear physician after MSc and then converted to oncology after completing his FCPS. He is examiner as well as paper setter of CPSP. He is a finance secretary of Pakistan Society of Clinical Oncology. Now I would like to invite Dr. Asghar Hussain at the stage for his presentation of TKIs in the thyroid cancer. Dr. Asghar.
Thank you very much. So, after going through this much extensive discussion about this management of thyroid cancer, where the role of oncologists come, when you think that the tumor is now radioactive iodine refractory and not a feasible candidate for further radioactive iodine therapy, so you can switch them, you can send them to oncologist, or being as a good nuclear physician, you can do it yourself also. It's not so a big rocket science. When to start TKI and which TKI. This is my topic of my presentation today. And you know it very well that all the patient doesn't need TKI. There is certain limitation to start this TKI, and we can observe such patient until unless there is a progression. As per the recommendation, TKI should be started when there is something 20% increase in the tumor size from the baseline after getting the refractory disease. You started with the tumor, and let's see there is some deposit in the lung or there is some deposit in the liver, which the surgeons say it's not resectable. Oncologists say it's very difficult to radiate that area because it's a part in the lung or it's a part in the liver. So, and chemotherapy is not having good effect. We used to give some chemo, doxorubicin, Paclitaxel initially. So what to do then? It's not a recommendation that we should immediately start TKI. We should wait till there is any progression, even if the TG is going high. If TG is going high, but tumor is silent, tumor is there, not increasing in size, the recommendation for increase in size is 20% increase in 1 year. Let's see if the tumor size was 1 centimeter, now it's 1.5 centimeter, this is something increasing. But if it remain 1 centimeter, I think nothing to worry about this tumor size. Patient most of the time, when you're referring this patient for TKI, they're asymptomatic. So, if you're going to give TKI, you can make them some symptomatic on the basis of their side effects, rather of having some good improvement of this use of this TKI. So, and also still a good hope for the nuclear physician, even after the start of this TKI, you can have a redistribution of iodine after a certain period of time. I'll show you the data that you can have the redistribution or reuptake of the iodine scan, and still the role of nuclear physician will come again, and we can send them back to the nuclear physician that give another dose of iodine therapy because it is recommended now. I'll show you the picture and I'll show you the data. So what is this TKI? All my those colleagues who are just in the learning phase, students, residents, TKI. If you just see from this simple picture I have put on the front page, this is the cell membrane, and in the cell membrane there is extracellular part of the cell membrane and there is intracellular part of the cell membrane. Both have different recommendation. Extracellular part has different recommendation for the treatment and intracellular part have different recommendation. You can block this extracellular part with the monoclonal antibodies. When I use the word of MAB, monoclonal antibody, it means it's some drug in the form of infusion or injection. When I use the word of TKI, it means there will be the word in the end of this drug NIB, like sorafenib, lenvatinib, solanezumab. So all NIB will be in the form of oral form. So all NIBs are TKI. All them. So you can stop, you can block the intracellular domain of any signal through this TKI, or you can further block intracellular domain with some other TKI which are recommended according to that. So start from with all this, you know it very well, the treatment of the DTC, differential thyroid cancer, surgery, iodine, hormone replacement, and limited role of EBRT, surgery, chemo, and all these things. If you just recall your physiology, from very basic physiology, sodium is very important. If you want to take any of the molecule inside the cell, you need sodium. Like if you want to shift one glucose molecule inside the cell, you need 2 molecules of the sodium. Similarly, one phosphate, you need 3 molecules of sodium. Same way, in iodine, you need 1 iodide molecule to be taken inside, you need 2 sodium molecule. So this is called symporter of this sodium iodide symporter. When there is some refractory disease to this issue, this blockage or this pathway is blocked, or you can say the cell forget to take out due to some reason that it has somewhat now become resistant. As you keep on giving antibiotic, then the cell become resistant to this antibiotic. Same way, iodine is there, but not taken up by the cell. So this could be the reason that this supporter is not working. And if you another slide from the iodine is taken up by the cell from the circulation. It is then conjugated and the oxidation there, and then it's formation of T3, T4. It's a very simple phenomenon from the thyroid follicle. 20 to 25% of the thyroid disease, when become metastatic, they are resistant to your iodine therapy. What should be the maximum dose and how frequently you can give iodine? Until unless showing avidity you can give. If it is not, then definitely it's a refractory disease. So if you just see, even if it become refractory, still you have a median survival of roughly 5 years plus. Thyroid cancer is the only cancer in our field of oncology where we talk about the 10-year survival. As compared all the tumor would say about 5 years survival. The thyroid cancer would say it's a 10-year survival. So even become it's refractory, still patient is not going to go anywhere. There is high chances. But if you're going to have some iodine uptake disease, your median survival is roughly 15 years plus even now when it's showing the uptake. So it's a very good tumor, and prognosis of this tumor, even the stage 4, is quite good. Now something basic about the immunity and immunotherapy, you know that we have the different cells in the body. Some are called innate immunity, some are called adaptive immunity. In adaptive immunity, we have a B cell which form the antibodies. We have T cell which form the CD4 and CD8. What is the difference between innate and adaptive? Just in one slide. Both have the first line of defense, innate and adaptive. But it is an immediate response. This takes some slow response. It is non-specific. This is specific. Once there is some antibody has been formed, it will remain in the body. It is not taken into the memory cell. This is taken up into the memory cell. This is usually by the natural killer cell, and the neutrophil, this is usually by the CD4 and CD8. In our immunotherapy, in the field of oncology, this is the CD4 which is having the major role in the management of the immunotherapy. And what we do in antigen, in APC antigen, when the antigen inside the body, it is taken up by the APC. APC binds with this your CD8 and form more T cell. Same way in the CD4, it form more T cell. T cells, when it infiltrate into the cell, if you just see, this is a tumor, this is the antigen. Antigen is taken up by the APC, dendritic cell. Dendritic cell takes it to the lymph node where the T cell are rich over there. T cell is activated through the circulation and reaches up to the site of the tumor, and then there is a tumor infiltrating lymphocyte. The cell or the tumor which are having more TIL, they are having good prognosis as compared to having low tumor TIL. So tumor rich in TIL then going to take up this tumor. Now, how the TK going to take up? When there is extracellular domain, we have monoclonal antibody. For the intracellular domain, we have different receptor like VEGF receptor, vascular endothelial growth factor receptor, platelet derived growth factor receptor, EGFR, RET receptor. They're all in the intracellular domain of the cell membrane. But in the within the cytoplasm, we have different domains, and we have the BRAF, MAC, c-KIT, mTOR, ALK, PIK3, all these are the mutations. So if you block this pathway, you need some inhibitor, you need some drug which can block. If you can't block these signals, there is more proliferation of the cell, there will be more angiogenesis, there will be more neovascularization, so there is going to have a more tumor cell proliferation. So you can block by using some TKI at this level, or you can block some using TKI at intracellular level. So in this way you can better control the disease by blocking these signals. If you just see this one, if this is the RAT PTC mutation over there, and it's going to activate the RAS pathway. RAS pathway includes this BRAF, NRAS, KRAS, all these different pathways. RAS is going to activate BRAF, BRAF is going to activate MEK, MEK is going to activate ERK. When this pathway or cascade is signaling is there, tumor cell will be keep on growing. Or you can activation of this RAS, this can activate the PIK3CA pathway, which is going to act on AKT, and AKT is going to act on the mTOR. We have the drug against mTOR, we have the drug against PIK3, we have the drug against BRAF, and we have recently started the drug with the ERK also. So these are the different drugs coming, but they are going to act on this level. If you can block this RAS by any mean, we have the drug with the lenvatinib, we have the drug with the cabozantinib, we have the different drug. I'm going to give you one by one. You can stop this blockage also at the vascular level, so that there is no new vascularization. You can block this VEGF receptor pathway, you can block this fibroblast growth factor receptor. There you can have a different drugs against available. In thyroid, specifically in the thyroid, these are all receptors which can have overexpression. If you can detect that this overexpression is there or not, you can treat in a better way. But if you don't know, or if these tests are not available, then the simple one, start any anti-angiogenic multi-kinase pathway. I'll give multi-kinase inhibitor MKI, which can be used against like many other receptor blocker. If you just see this one, this was the famous drug we used to give, the sorafenib. It is MKI. This can block the VEGF receptor. This can block the PDGFR. This can block KIT. This can block react the FLT also. So it is MKI. Sunitinib, axitinib with the name Enlita, sunitinib suited is yet not. Very good drug for the management of medullary thyroid, for the renal cell carcinoma. All these drugs are plus minus available by different means. No, and the drug which is available, and I'll show you the data also, which is effective against many receptors and available also, registered in Pakistan also. We can use this one, is with the name of lenvatinib. Okay. So lenvatinib can be used as a anti-MKI. If you just see this one, select trial, ये 2 मिनट में ना ये ऑफ कर दीजिएगा, ये जो दरमियान में ऑफ हुआ है, माइनस करना होगा, ऑन करें प्लीज, पेपर में लेट आए ना तो उसको एक्स्ट्रा टाइम देते हैं जो लेट आता है. So we have the very famous trial with the name of SELECT trial. On karo beta. So lenvatinib, sorafenib, cabozantinib, axitinib, or solomatinib, these are all TKI, which is somewhat available in different form, different ways in Pakistan, but the registered one is the lenvatinib and the sorafenib. We are using the lenvatinib, and the dose of the lenvatinib is quite high in thyroid as compared to the other tumor. This was the SELECT trial, and if you just see the SELECT trial when was compared with the placebo, there is a HR ratio 0.21. 0.21 is quite significant HR ratio, and there was a difference of 3 versus 18 month median progression-free survival, roughly 1.5 year plus median progression-free survival in all those patients who were refractory to your iodine therapy. So lenvatinib with the dose of roughly 24 milligram, usually we give 8 or 12 milligram, 24 milligram, you can use 10 milligram one capsule and 4 milligram one capsule. This is the DECIENT trial, and here they compare the sorafenib with the placebo. This is the difference of 5 versus 10 month. Same way, if you just see, it's not easy to use. If you're planning to start yourself as lenvatinib, must check the 44% grade 3 hypertension rates is there with the lenvatinib. Grade 3 hypertension means that their blood pressure can go up to 160 millimeter mercury plus with the lenvatinib. So if the patient already having hypertension, you have, it's not as such contraindication, but you can have a good control of the blood pressure. All other side effects are plus minus. If there is a vendatinib phase 2 trial with the name of Caprelsa, good drug for the medullary C thyroid, this can be used, and this is a difference of 5 versus 11 month. If there is a failure of this your lenvatinib or sorafenib, then this is cabozantinib. This trial has recently, yesterday has been published or presented in the ESPO 2023 in Madrid, Spain, and they have used the cabozantinib against the different physician choice drugs, and they have good response. Cabozantinib with the name of Comitrex, it's available. It's being used for the many other tumors like renal cell carcinoma also. And even if there was a progression on this lenvatinib and sorafenib, you can have a further improvement of roughly 5 to 6 months with the use of cabozantinib. Now these are the different drugs. If the anti-RK inhibitor, you have to give entrectinib with the name of Rozlytrek or larotrectinib with the name of Vitrakvi. Same way, if the PTC in oncogene inhibition, we have selpercatinib with the name of Retivmo or praseltinib with the name of Gavrito. For BRAF mutation, we have vemurafenib with the name of Zelboraf and dabrafenib with the name of Tifinler. And the same way for PIK3 inhibitor, we have the everolimus, or we have the name of alpelisib with the name of Piqray. So these are the different drugs which can be used according to their mutation, and you can see their response roughly is around 50% plus. But these mutations should be there. If these mutations are not there, then these drugs may not be so in. So for generally, for when there is no mutation, then lenvatinib is a good option. But be careful when you're going to ask for any anti-angiogenic MKI like lenvatinib or bevacizumab. There should be no surgery within 28 days. There should be no active bleeding. There should be no brain hemorrhages. There should be no carotid encasement. There should be no any thromboembolic event in the last 6 to 12 months. Response evaluation after 2 to 4 months. There is no role of FDG PET in the radioactive iodine refractory disease. Rather the PET which is recommended, that's iodine 124 PET which is recommended, not FDG1. FDG PET can be done in this medullary anaplastic and another one, but not in this. Redifferentiation. Redifferentiation is possible especially when there is a BRAF mutation is there. And you can see these were the patients who were treated with the initially iodine, then become refractory, and then they were, when they were given the solumatinib will come with the name of Crisivo I think. And there was further redistribution of this iodine, and they responded with same way. This was the lesion, not iodine uptake, but with the solumatinib there was uptake again over there. So there is a redistribution option there in such patient. So this is my last slide. This is a quite jumbled slide. You can say the final conclusion of this slide is that if you have an option for NGS sequencing, as has been started by the PINAM, you can ask for the target mutation checking or the 27 gene panel or NGS, which we are going to start soon with the Dr. Shazia Fatima has started this NGS sequence with the third generation, first NGS in Kiran Karachi. We have started the BRCA testing, and soon we're going to start the whole genome sequencing also, inshallah, in Karachi. You can send or you can start this patient checking their mutation level, whatsoever the mutation is there. Even you can check the TMB level, you can check the MSI level. If they are there, you can start with the pembrolizumab also. So if you don't know anything, any mutation, start with the lenvatinib, which is going to have a good 1 year plus progression-free survival. If not, then if lenvatinib is not available with you, you can start with the sorafenib also. So these patients remain very well on this cure management. I think this was the last slide. Thank you very much for listening.
I would like to skip question answer session for this talk as there is shortage of time, but any of you have any question, Dr. Asghar is here with us for next 2 hours. Any of them can ask him. Thank you, Dr. Asghar, for your insightful presentation that will be really conductive for all of us in the management of thyroid cancer, especially in the selection of TKIs. I really apologize for the disturbance due to some technical as well as electrical issues during your talk. Now, I would like to request Dr. Muhammad Suhaib to share his closing remarks and reflections on this session. Dr. Suhaib.
Thank you very much, Dr. Azra. We have had very good talks this morning, which were very informative and very well presented. The first one was by Dr. Jing Wing, the president of Chinese Society of Nuclear Medicine, in which he described the growth of nuclear medicine in China in terms of the departments, which has grown from 600 to nearly 1100 departments of nuclear medicine throughout China. And then the growth of equipment, the staff, and the indigenous development of the equipment. This next 4 lectures were on thyroid cancer. The first one was by Dr. Basit Iqbal, which was role of SPECT-CT in management of thyroid cancer. He showed some cases where the SPECT-CT would be helpful in making decisions in thyroid cancer management. And then we had thyroid cancer management comparison of guidelines by Dr. Adnan Said. He showed us described the guidelines of different parameters of various guidelines for thyroid cancer management. And then Dr. Muhammad Babar Imran, he told us the parameters to incorporate genetic analysis in management of thyroid cancer in comparison with the conventional model which is being followed. And lastly, Dr. Asghar Hussain Asghar, he told us the role of tyrosine kinase inhibitors in management of thyroid cancer. Thank you very much for your presence, all the a good number of audience here, and thank you, Dr. Shazia.
Thank you, Dr. Suhaib. Finally, this is the end of first scientific session of our last day. Now, I would like to request Dr. Shazia Fatima to present the shields to our speakers as well as chairperson. First of all, Dr. Basit Iqbal, kindly come to the stage for your shield. I would also invite Dr. Noza kindly come to the stage to honor our speakers. Thank you, Dr. Noza. Next, I request Dr. Adnan Saeed to kindly come to the stage. I request Dr. Muhammad Babar Imran to come on the stage to have his certificate as well as shield. Next, I would request Dr. Asghar to kindly come on the stage and have your certificate and shield. I really apologize Dr. Muhammad Suhaib to give us his precious time in the early morning session and request him to kindly have his shield and certificate from Dr. Shazia Fatma. Dr. Suhaib. I request Dr. Noza to kindly present the shield to Dr. Shazia Fatma for chairperson our session. And at the end, me, myself, as a moderator. We are a bit late for our next scientific session. I would request Dr. Irfanullah to kindly come on the stage and moderate the next and the last session of our last day. Dr. Irfan, kindly come on the stage.
There is one announcement as well. When you leave, the certificates are placed on the registration desk, so participants can collect their certificates from the registration desk. And secondly, mark your attendance. Attendance sheets are placed there, so these are also there. You can mark your attendance. Thank you.
Thank you, Dr. Azra, for introducing me as a moderator. I am going to start the second session of this day of the PSNM Symposium. Our first speaker is Professor Dr. Yun Sang Lee. Professor Lee is a distinguished full professor in the Department of Nuclear Medicine at the College of Medicine, Seoul National University. Professor Lee is a prominent figure in the field of nuclear medicine and radiopharmaceuticals and has made significant contributions to the development of novel radiopharmaceuticals, including lutetium-177, gallium-68, and fluorine-18. He has published over 134 research papers in internationally renowned journals, which have more than 3,500 citations. It is my pleasure to invite Professor Lee on the stage. He will talk on the presentation, Radio Nanomedicine for Theranostics. Okay, Professor Lee, please.
Okay. Assalamu alaikum.
Okay, I have also the privilege to invite our chairperson, Dr. Muhammad Wasim, and co-chairperson Muhammad Nadeem Saab. Please come on the stage. Okay, Professor. Thank you.
Okay, thank you for the kind introduction. Today, I will talk about some unfamiliar story to the nuclear medicine physician that is related with nanomedicine. But I think sooner or later that kinds of radio-labeled nanomedicine can help the development of nanomedicine or itself that can be used as the theranostics. I think you may know that chemistry, that nano is the field of chemistry that word from the Greek word nanos, it means dwarf. So simply that nano is the size dimension. So 1 to the minus 9 is the nanometer size. And firstly, Nobel Prize winner Richard Feynman, he said that there's a plenty of room at the bottom. So that means we can magnify some material into the nano size that has some kinds of different phenomenon in the field of research. So you can imagine just 1 cubic centimeter material is divided into more than small pieces, then that can possess that high surface area. So high surface area can produce that some kinds of different properties of that material. So we think that there is some kinds of quantum effect dominate in that kinds of small size particle. So in case of gold, that is divided into the small size, just like a nanometer size, then that melting point has been changed, and also color or fluorescence and electrical property or magnetic property has been changed. So you can see here you can see here that 20 nanometer sized gold nanoparticle possess that the color has changed, just like wine pink color, and bigger size possess that the purple colors. So in the nano means under the micrometer size. So, but normally 1 to 100 nanometer is that defined as a nano in NNI from US defined that kinds of dealing with 1 to 100 nanometer is for an industrial field. So related science, actually that is basic for chemistry and also physical that inorganic chemistry, or sometimes we can apply it with molecular biology or other scientific field. But human race, earlier our human race adopt this technology into the kinds of Damascus blaze, and also that blaze contains that carbon nanotube, and also stained glass, that golden nanoparticle can show the different colors of the glasswares. So after almost 30 years devotion of the scientists of the nano field, they produce so many kinds of industrial products, such as quantum.TV or quantum something like a nano industry field. But they eagerly want to apply this nanotechnology to the medicine. Because of that huge surface area that can be applied with the multifunctional application, and also small modification that can change it into excretion or clearance in time, and also some nanoparticle has a porous structure that we can deliver the drug inside of the nanoparticles. Up to now, I think in vitro sensing is commonly used for nanomedicine, such as ultrasensitive nanosensing, also biomarker nanoimaging, or sometimes drug delivery vehicle. Sometimes we can use regenerative medicine. But we consider several factors for nanomedicine. You have to consider that the core synthesis. Sometimes we can make a hard core, or sometimes we can make a soft core nanomaterials, and also surface modification that can be applied for human use. And for radial labeling, we have to consider that the bifunctional chelating agent and size and charge or shape will affect the biodistribution inside of the body. And also toxicity is a very important point for, especially for nanomedicine. Year of 2009, already that the size matter of the nanomaterials can differentiate the biodistribution. So up to 100 nanometer that can engulfed by the corpuscle in the liver, and less than 5 nanometer, and they are excreted via the kidney excretion. And also positively charged nanoparticle that can harmful for a cell, that can possess that cell toxicity. I think in nuclear medicine already we use the nano system for imaging, such as technetium HSA. They can visualize the GI bleeding, or nanocolloidal structure. They can help to find the lymph node or lymphatic systems. And radio-labeled nanomaterials that can help the whereabout the nanoparticles, such as we can get the imaging or tissue-based biodistribution study. For the radio labeling part, I think we can think that simply bifunctional chelating agent we can use for the radio labeling. That is the easiest way to radio labeling. And surface labeling, that means the surface of the nanoparticle that can that radioisotope can attach to the surface of the nanomaterial, or sometimes we can mix with the core material with the radioisotope. So after the radio labeling, we can do the imaging or biodistribution study. Firstly, as I mentioned, that I'm a radiochemist to visualize that whereabout the nanoparticles. So firstly, we set up the radio labeling method for each nanoparticles. So at more than 10 years back, we got several kinds of nanomaterial from our country, and then I attached the chelating agent on that, and then radio labeled it. But sometimes it's went well, and then sometimes it took more than 5 years to radio labeling set up. So I struggled for that kind of radio labeling on the nanoparticles. So my mentor, Professor Jae-min Jung, proposed that, okay, that Yun-sang, you simply mix with the chelating agent or targeting molecule, and then you can get encapsulated nanoparticle. So we published the year of 2012. And you can see here, twin 60 or twin 80 is an amphiphilic molecule that can possess that hydrophobic chain, and also they can contain that PEG molecule on one molecule. And then they mixed with the nanoparticle, we can get very stable, stabilized or hydrophilized nanoparticle by ourselves. And after the radio labeling, you can see here that the tumor site, that nanoparticle distributed to the tumor site, and that is blocked with the specific molecules. So that is the all-in-one step functionalization kinds of things, and all the hydrophilization agent and functional the targeting molecule, and also chelating agent mixed with that can form a micelle, and then into the micelle solution that hydrophobic quantum dot or any kinds of hardcore materials drop into the that micelle solution, and then we can get hydrophilized nanoparticle. And after that, we evaporate the chloroform or hex and normal hexane, and then we can get hydrophilized nanoparticles. So that, firstly, we applied that thing to the quantum dot, and next one is the iron oxide nanoparticle. And we calculate the sugar moiety on the nanoparticles, and we can do because of that iron oxide nanoparticle can see the MR signal, so we can do the PET MR and PET study. As you can see here, after the hydrophilization, that nanoparticle possess that very monodispersed structure size, and you can see here after the hydrophilization, encapsulation, just 10 nanometer size. And also under the high salt concentration, there is no change of the size, and after the radio labeling, there is no change of the size. So we apply that iron oxide nanoparticle to the lymph node imaging, in vivo lymph node imaging, that nanoparticle injected into the foot pad. And can you find any the darkening side of this image? But I couldn't find. But after get information of the pad part, and then we can magnify this area. And then finally, we could find that some particles aggregated in this portion. So that means we inject a small dose, almost 10,000 times less dose than the earlier Feridox or kinds of ML contrast agent. So we think that that radio isotope labeled nanoparticle, nanomedicine can help reduce the toxicity of the imaging of the kinds of lymph node imaging. So we think that radio nanomedicine can help that nano better or radio better property of the nano product. And then after that, we radio labeling procedure did in on a inside of the just the solution, inside the solution contains that the nanoparticle. So after that, we try to make a click chemistry on the nanoparticle. As you know that last year, click chemistry got the Nobel Prize in chemistry. Click chemistry is just a concept. That is not the specific chemistry route, just simply easily formed and also easily separate from the starting material, and also even physiological pH in water that can be formed some kinds of molecules. So that is defined as a click chemistry. So firstly, copper was used for a catalyst for click chemistry, and also later on, copper-free click chemistry was developed by the Bartholdi, Professor Bartholdi, and then that can be used as a radio labeling procedure for all the peptide or nanoparticles. So we think that that clickable nano platform can be applied for nanomedicine, such as targeting molecule decoration or just a radioisotope attached to the nanoparticles. Sometimes we can apply different kinds of radioisotope, such as a copper, lutetium. We can doubly labeled with one nanoparticles like that. And all set of the click chemistry on a nano platform, we focus on the nature invented nano platform, such as albumin. I think an NM physician, you can understand what is the meaning of this image. This is the blood pool imaging agent, such as a technetium, just like a technetium HSA imaging, but somewhat different because of the after 4-hour injection, you can see the high blood pool activities, including carotid artery, and we think that that is somewhat different with the earlier technetium HSA imaging, because after the injection, within 1 hour, all the radioactivity go into the liver, even in a mouse and also human. So what is the difference? So we think that that click chemistry applied human serum albumin, that radio labeling procedure is outside of the albumin. But technetium HSA radio labeling procedure is so we use the highly reactive tin chloride. That tin chloride solution can meet human serum albumin. So we think that that earlier technetium HSA is not the real meaning of human serum albumin. So we think that copper clickable human serum albumin can maintain the nature of the serum albumin. So that's why that blood circulation time is highly increased. As you know that almost 60% of protein in human blood, and also just a simple small modification can reduce the half-life. So after that, I got the patent of this conceptual study. Then after the clickable albumin nanoplatform can attach the radioisotope or targeting molecule or therapeutic drugs. And after that, we set up all the chemistry, and then we calculate how much molecule on the albumin nanoplatform, and then we can do the images with the diagnostic or therapeutic radioisotope. And firstly, we attach the folate for a targeting molecule. You can see the KB cell line that highly expressed of the folate receptor. So you can see here high uptake inside of the tumor, inside of this cell, and that is blocked with the folate. And after that, we got the in vivo imaging. And you can see here, tumor inoculate the model. You can see the high uptake in the mouse model. And after that, okay, thank you. So after that, we attached the galactose and mannose molecule. That is the simply two position carbon and 4 position carbon contains that the hydroxy molecule different. But one albumin can decorate the only 3 different carbohydrate. But you can see here that galactose labeled albumin can show only hepatocyte, but mannose-related albumin only show the corpuscle. So I found that in the textbook that our image and textbook is almost same. That this is the ex vivo imaging, so just simply mixed with the galactosyl albumin and mannose albumin and into the IV injection, and then after getting liver tissue, and then we can see there is no staining or like that. So we apply this thing to the metastasis imaging, and then also applied to the technetium radio labeling method. And also we can apply the, I think the day before yesterday, we discussed about the boron neutron capture therapy that can, the albumin nanoplatform can be applied for BNCT also. So my final goal would be already we set up all the kit formulation of these albumin nanoplatforms, and that can be used diagnose or therapy or theranostics for human use. So already I set up all the kit formulation, and monthly we produce more than 100 vials. And then if you want, I think maybe sooner or later, Dr. Nadim Lodi will get these kinds of kit formulation, and then he will apply this kit for new pharmaceutical production. Okay, thank you very much.
Thanks a lot, Professor Lee, for an excellent presentation on various aspects of nanomedicine. Now, since we are already short of time, we may have a time for 1 or 2 quick questions. If there is any question.
Thank you, Professor Lee, for your nice presentation. We know that nanoparticles have property to penetrate through the cell membrane. So the long biodistribution may be due to this cell penetration property, or there is inbuilt binding for nanoparticles.
Yeah, you are correct. But that depends on the nanoparticles, because of the cell penetration property is almost a 2D cultured cell line. But in case of 3D cultured cell structure, that tissue-based monitoring, that cell penetration property is dramatically decreased. So that means that is from the gravity of the because of the nanoparticle has a high density molecule structure. So I think yes, that any kinds of nanoparticle can go to the liver. But sometimes we can see the lung, that means aggregated form of the nanoparticle. So I think we can discuss later on after this session.
Okay. It seems that then there is no further question. So we thank our speaker very much. Our next speaker in this session is Dr. Sobhani Ukarvi from Saudi Arabia. Dr. Sobhani is the chairman, senior nuclear medicine scientist at the Cyclotron and Radiopharmaceuticals Department, King Faisal Specialist Hospital and Research Center, Riyadh. He obtained his PhD from the Catholic University in Belgium in the field of radiopharmaceutical science and postdoc training from the University of Alberta in Canada. He is a diplomat of the American Board of Science in Nuclear Medicine and American and European Board Certified Nuclear Pharmacist and a fellow of the American Society of Nuclear Cardiology. He has more than 100 publications as articles, abstracts, and book chapters. His research interests include the development of new small biomolecules and peptides for the targeting of tumors and other chronic diseases with eventual clinical translational research. A topic of his presentation at this forum is peptide-based radiopharmaceuticals, useful tumor targeting agents. Professor Subhani, please.
Thank you so much. First of all, I want to thank Dr. Shazia for inviting me here. I know very few people here because maybe they are not interested in basic science, but I want to tell one thing, that without making a good radiopharmaceutical, you cannot do good imaging. Whatever camera you use, if you don't make a good drug, you will not get good imaging. So I think basic science has a very critical role in nuclear medicine. So I think there should be interest from physicians also to take interest and participate in this session. So KFSH King Faisal Hospital is a tertiary care hospital in Riyadh. We have 1,600 beds. We have more than 10 cameras, very modern. And on top, we have 3 cyclotrons that we built about 40 years ago. And we produce more than, and we have about 15 hot cells where we would do all GMP practicing. And we produce about 30 radiopharmaceuticals. They are both diagnostic and therapeutic, including technetium generator. And we supply these to the 50 hospitals in the kingdom. On top of this, we produce FDG 3 times a day, about 5 curie, and we supply 50 hospitals and 150 units every day. So our department is a service provider, and also we have a small R&D department where we make new drugs. So we make, for example, fluoroestradiol, PSMA, ammonia, FDG, choline, DOPA. So all different types of PET isotope that you can imagine. On top of this, we can make fluoride, FLT, dotatate, PSMA with lutetium and with gallium. As we are talking a lot about peptides, so what are the peptides I will discuss briefly in this presentation. You know this dotatate they are talking. Basically, dotatate or somatostatin analog is 28 amino acids. I don't know if I... So this 28 amino acid is not stable in the body. So that's why they make analog, short analog of 8 amino acids, that you can see that this 8 amino acid has dicysteine bond. And initially it was labeled with indium. So the idea is to make analog that can be used as a theranostic, can be labeled with DOTA and also with lutetium and gallium. That's why they replace GTPA with DOTA. And another isotopes recently approved by FDA is copper labeled dotatate, which is DetectNet. The idea is to make it longer half-life because copper is PET isotope, but it has 12 hours half-life. So the shelf life of this isotope is 24 hours. So it can be shipped outside the country, another cities, and it has more better that you can do late imaging also. As I mentioned that we have mainly service department, but on top we do preclinical evaluation. I don't know how it looks. So these preclinical means we can do peptide synthesis, we can do animal imaging, we can do labeling, all types of things that need to be drugged for a new drug development. Why peptides? So I want to emphasize, compared to antibodies, peptide has different properties. For example, they are small in size, they can be synthesized chemically, and also they are easy to radiolabel because they have a small chain. So any isotope or any chelating agent can be attached. Because of the small size, they have rapid kinetics, they are rapid target issues, and also they are non-toxic. On top of this, they have a lot of receptors that can be used for targeting. So these all properties make peptide ideal radiopharmaceuticals. On our lab, we have interest on different types of peptides. For example, bombacin, because bombacin is a small peptide. Then we have mucin peptide. We have HER2. HER2 is derived basically from Herceptin, which is an antibody. Then we develop also a leuprolide peptide, which is for breast cancer imaging. We also conjugate PSMA with different peptides to enhance targeting efficiency. On top of this, we also conjugate peptides with cytotoxic drugs, for example, doxorubicin, also with folic acid, also we work on rhodamine. So our activities in the lab make us to be more useful in making new drugs for future applications. The one thing I want to emphasize that we also work with cardiac imaging, and in this context, we make rhodamine. As you know, rhodamine is like a MEB, and we try to make it with NOTA and labeled with copper because of the longer half-life. And as you can see, a very nice heart imaging here, and based on this discovery, I got this American fellowship because they think it's a useful compound for future application. So when we design a peptide, what is the criteria? The criteria is first you have to know the target, which target you want to target. For example, for breast cancer, it's a different sequence. For prostate cancer, it's different. Based on your target, you design your peptides, and then you attach a linker. Linker can be amino acid, can be any molecule, and also depends on your application, whether it's diagnostic or therapeutic, you have to attach with that one. So all these criteria, you have to plan ahead before you design a peptide. For example, somatostatin receptors, you know that you are targeting neuroendocrine tumor. So then you have to attach your somatostatin or octreotide analog here. Then you do your linker and attach with, for example, DOTA. DOTA has the ability that it can bind with any isotopes. You can use lutetium, you can use copper, you can use zirconium, depending on your availability of the isotopes. So all these making isotopes for theranostic, diagnostic, all depends on your molecule that what you want to apply. So our interest in our lab that we do our own synthesis. So we have this facility that we can synthesize our own peptides. And for this peptide synthesis, we don't need a machine. We can just simply use a funnel, which is very simple, that you simply use resin, then you attach your amino acids, and at the end you attach DOTA. So you can make your own peptide depending if you have this availability in your facility, and need also a little bit experience and technical information. So our interest also, because peptide alone sometimes is not enough, so you have to add some doxorubicin, some anti-cancer drugs. So peptide can be used as a carrier. So when you use carrier, then you can use any drug depending on your application. So we use this receptor binding peptide as a carrier to take these cancer drugs to the target. In this way, it's more specific, less toxic than conventional chemotherapy. Also, we try to use different peptide cocktail. As you know, only one peptide sometimes is not enough. So you have to use peptide cocktail, or you have to use 2 different drugs conjugate with peptide like antibodies, and you can use nanoparticles. We are trying also estradiol because estradiol is ER positive. So the idea is to make dual targeting, so you have more receptors, and so your targeting efficiency will be higher. As you know, gallium is available in the form of jet generator as in technetium, but because gallium has 68-minute half-life, so our idea is to produce gallium from cyclotron. In this way, you can make more drugs, more doses, because with generator you can get only 50 millicurie, but with cyclotron you can make up to 500 millicurie. And if you have high demand of gallium dotatate or gallium PSMA, in this way cyclotron production is very important that can allow you to make multiple doses. In terms of gallium kit, it's like a technetium kit, so you have your precursor available in that vial. So you have to adjust pH 3 to 4, you heat it, then you do SEPAC purification to remove unreacted gallium, and then you have pure sterile product of gallium-68 product that you can use for the patients. Why I'm telling you, because I noticed that some people complain about, for for example, imaging, making extra doses. So I think first thing you have to make sure that whatever you are injecting to the patient is up to the standard. So you have to do all quality control specification tests before you can make sure that what you are injecting is up to the standard, and you can expect good imaging after injecting good radiopharmaceutical. So for the newcomers, labeling is very simple. So you just have your peptide, you just adjust pH with sodium acetate, you add gallium and simply heat. So these are very simple reactions for gallium labeling. Same way you can do for lutetium. In lutetium, you use also gentisic acid, which is anti-ascorbic agent. Because lutetium is high energy, it forms radiolysis, so you have to prevent that radiolysis. That's why you have to add some gentisic acid. What is theranostic? People are talking theranostic, but the idea of theranostic is to use one drug for both diagnosis and therapy. For example, you use somatostatin, so the drug is same. The only thing you are changing is the radioisotopes. So in this way, you don't have to get two approvals from FDA. One drug can be used for the approval. So the same peptide can be labeled with, for example, if you want lutetium for therapeutic, gallium for diagnostic, copper 64, zirconium 89. So all these possibilities are available for labeling with the same peptide, and they use two purpose. We are working also with PSMA. As you know, PSMA is highly expressed in prostate cancer, and its expression is about 1,000 times higher. So whenever you make any drug for the receptors, you have to make sure that it is highly expressed on receptors and low expression in normal tissues, because you don't want radiation to the normal tissues. PSMA in this respect is useful because it's highly expressed. As you know, for prostate cancer, prostatin is the antibody, but we are not interested in antibody because it's expensive, larger size. So out of antibodies, we make a small molecule called glutamate. So as you can see, this molecule, this is a very small molecule that can be used for PSMA, and these contain urea base. And you have this amino group that can be attached to any molecule like peptide to make it linker. In this way, you can synthesize your own PSMA. In our lab, because we want to use PSMA for different isotopes, so we make technetium version of PSMA, we make copper version of PSMA. So in this way, we do our own chemistry. So we start, for example, I don't want to go in detail. So we can use, for example, DOTA for copper, 64, gallium. But on top of this, we also make it fluorine version, because fluorine has longer half-life than gallium. So you can make more doses. Also, on top of this, you can make it technetium version. So in case people has no gallium, no fluorine, they can use also technetium version. So what you do, this is your basic unit that binds with the PSMA receptors. Then you can use linker, and then you can attach this chelating agent, which also can be synthesized on peptide synthesizer. These are simple amino acids that can be used. So PSMA, as you saw in yesterday's lecture, can be used more than prostate cancer. So we are trying to do preclinical testing of PSMA in triple-negative breast cancer. We do some animal studies, and this work is in progress. I don't want to discuss because these are under patent. So our interest mainly on bombesin peptides. Why bombesin? Because bombesin is 7 amino acid peptide. It is very linear. And you can see this 7 amino acid peptide, that this side is free. So you can attach any linker, any chelating agent here. So you can use for lutetium, gallium, technetium, fluorine, depending on your application. So the idea of peptides that it are flexible. So you can do a lot of modification based on your requirement. And also bombesin receptors are expressed on prostate, lung cancer, breast cancer. So it's very unique peptide that can have further application. Another peptide we are working is mucin. As you know, epithelial cancer express a lot of receptors for breast cancer, ovarian cancer, and this has low expression. So we are also trying to label this peptide with different isotopes for further application. Also, we are working on HER2 peptide derived from Herceptin. Herceptin is an antibody FDA approved for breast cancer, but we are more interested as a shorter version. So we take this peptide for further application in breast cancer. Also folic acid, because folic acid is expressed on breast cancer, and methotrexate is anti-cancer drug. So these compounds can be labeled with drug peptide to enhance targeting efficiency. Fluoroacidiol is another approved compound that can be used for ER-positive cancer. So we are making fluoroacidiol as a DOTA because we want to label with lutetium also. So we are trying to make some changes. Another isotope which is very useful for future application is zirconium-89. As you know, zirconium-89 has long half-life, is a PET isotopes, can be used for antibodies, can be labeled, and then you can do imaging next day. This is the first PET isotope that can be labeled and used after 2-3 days. So it has very potential application. So we are working on the production of cyclotron produced zirconium-89. In this way, you need this energy. Then we have to confirm the identity. When you make a new compound, you have to make sure that this compound is pure. It can be used for the patients, and it contains no impurity. And then we do all, okay. So we do all this purification to make sure, then we do radio label. We label with DOTA PSMA, and you can see it's very clean product. And also then we do animal studies to make sure that we are using for targeting. And also we do PET-CT, animal, and then we have to make sure all these tests before we can inject to the patient, that the safety is very important, quality is very important, you have to meet all these specifications, make sure that this peptide is good enough. So we do all these clinical testing, I'm not going in detail, and then you can see that our steps are very, very extensive that we do. I want to emphasize one thing, that people who do research, they start maybe from 5 to 10,000 compounds. And it takes 10 years to make one compound. From 10,000, you can make one compound. So never give up. You always do keep good research. And I want to give you one result. So recently, this is for encouraging only, not for publicity, that I was top 2% because of if you keep doing good research, one day you will be rewarded. So always be hopeful, because research always very frustrating. You always get upset, but if you keep working, one day you will be rewarded. So our interest mainly is to translational research from bench to bedside. And finally, I want to thank all for listening. Thank you.
Thanks a lot, Professor Suhani Iqbal, for such a nice presentation. Again, we can have just 1 or 2 rapid questions, please. If there is any question. Okay, I think we don't have any question. So once again, we thank our speaker. Our third speaker of this session is Dr. Nadeem Ahmed Alodi. Dr. Nadeem is a principal scientist at the Pinstick. His current research focuses on the synthesis of peptides for peptide receptor radionuclide therapy. He has multiple international papers published in prestigious journals. He has been involved in the design and synthesis of innovative technetium and lutetium-based theranostic radiopharmaceuticals. Over the next few years, Dr. Nadeem Ahmed Alodi continued to flourish and evolve with recent developments of prostate specific membrane antigen PSMA for precise imaging and therapy of CA prostate. It is my pleasure to invite Dr. Nadeem, please. His a topic of presentation is preparation and clinical translation of technetium HYNEC PSMA for SPECT imaging of prostate cancer. Dr. Nadeem, please.
Thank you, Dr. Fanullah. First of all, I would like to thanks to the society, especially to Dr. Shazia, Dr. Inam, for inviting me here to give a talk on the preparation and clinical evaluation of technetium HYNEC PSMA for SPECT imaging of prostate cancer. So before going into the presentation, this is a little overview of the Pinstick. Basically, I'm from Pinstick, so it is called the Nuclear Taj Mahal and Physics Today in 2015. This is the night view of this Pinstick. It's a beautiful view here So, as you know, that we are producing indigenously produced radiopharmaceuticals kits as well as radioisotopes for the indigenously for the hospital and supply to the all nuclear medicine center in Pakistan. And this is the facilities, molybdenum plant production facility. This one is a generator, technetium generator facility and iodine production facility. And strictly onto the topic, because of short times, prostate cancer, some of the cancer, which is the mainly in the men in the United States, which alone accounting for the 29% of the total cancer. And different imaging modalities, imaging agents for the prostate cancer are the choline or MDPs or some androgen receptors and amino acid transporter, GRPRs and PSMA, small urea-based PSMA molecules. Out of them, PSMA is considered to be a good for the prostate diagnosis of prostate cancer, and as we know that PSMA is a trans-glycoproteins having a molecular weight of 100 to 120 kilodalton. And PSMA is expressed in almost all type of prostate cancer, and its expression correlate with the progressions, stage and the risk of the disease as well. And the modality which been routinely utilized in the clinic is a gallium-based or F18-based PSMA urea-based inhibitors for the precise diagnosis, staging and monitor the response of the therapy. And obviously these are some precursor which are being utilized for that purposes. PSMA 11 labeled with the gallium 68, or similarly F18 labeled with some other PSMA molecules, and there is another PSMA 1007 labeled with F18. However, as we know that PET-CT is not available to the all medical centers, only few hospitals has these facilities. And obviously it's very expensive production of galliums or F18. Obviously if they don't have a cyclotron, cannot be produced on sites. So alternatively, obviously most of the center have a small this SPECT-CT. They can be technetium PSMA can be utilized to monitor the response, or as well as staging and monitoring the response of the therapy in the patients. Pakistan, so technetium PSMA can be utilized for staging and monitoring the response of the therapy. So there are different type of PSMA, technetium PSMA molecule which is being into the pre-clinical or clinical stages. One of them is PSMA technetium labeled this PSMA molecules MIP1040, PSMA I and S, and PSMA Hynic PSMA, IPSMA, which is developed by the Mexican group. And there is one other PSMA molecule, Hynic ALG, which is developed by the Chinese group, PSMA T4, which is developed by the Pol atoms. So there are different PSMA molecules labeled with the technetium is being used in the clinical evaluations of or staging of the prostate cancers. And obviously, there is a debates about the diagnostic accuracy of technetium PSMA with the gallium PSMA. There are two images, if you see in here. One is with the gallium and other one is with the technetium. Is there anyone tell which one is the gallium and which one is the technetium's image? Okay. This one is a technetium I PSMA, and on the right side, this is a gallium PSMA. Obviously, if you see, you don't find any difference. Obviously, the lesion are very much with the technetium I PSMA as well as gallium PSMA. Obviously, the resolution and the sensitivity is kind of, the quality of image is different, but you can see the lesions in the both images. So with this, we come up with the idea that obviously most of the center in Pakistan, they don't have a PET CT. So we try to develop the Hynic ALG technetium kits for the easy preparation of this radiopharmaceutical at the hospital pharmacy. So this PSMA molecule is developed by the Chinese group, and it's a very simple molecule having a small urea molecule with the linkers. It don't have any lipophilic linkers. So, and then the chelator, Hynic is used as a chelator. And they have studies this, and there are a lot of study with this molecule and show very good uptake into the to the cancer, and it get prostate cancer, and it can differentiate, and it can localize into the mets of the and the lesion into the patient as well. So we performed some docking study, and this molecule show very high affinity with the PSMA, and we selected this molecule in our study. Then we calculated the KIV value. This is our docking and computational study basically. It show very high affinity with the PSMA. And then we synthesize this Hynic ALG group by using a solid phase peptide methodology. I will not go into the detail. And obviously we will get finally this compound having a urea lysine kind of like a molecule which is being used in this study, and as well as Hynic as a chelator. So this molecule, we purified it and we characterize it, and then we prepared the radiopharmaceutical kits for this one, and we check the quality controls by using radio HPLC and radio TLC as well. And obviously sterilities, endotoxin tests, we perform all of these tests. It show a very good radio labeling efficacy and purity as well. And then we gave these kits to the different medical hospitals, and especially to the Kirans, and they perform some clinical study of this kits, and it show very good distribution into the to the body. And obviously lacrimal gland, if you see, is very visible here, which show a high expression of the PSMA as well as a kidney. Kidney also have a PSMA expressions, so it show uptake into the, and obviously the lesions show the here if you see the lesions, it show uptake into the lesion side. So this showed that the kit is good for the diagnostic of the prostate cancer as well as the metastasis in the patient. So this is a second case. It show very good uptake. It show very good uptake into the lesions. Lacrimal gland is very clear. So the kits is obviously working very fine, and it can be used for the diagnosis of the prostate cancer. And then obviously this molecule it don't have any lipophilic kind of linkers. So we thought that introducing because there is some publication and literature show that the PSMA pocket has a lipophilic kind of like pocket inside. So if there is any lipophilic linker into that PSMA molecule, it will show the affinity, higher affinity to that molecule. So we starting working on one other PSMA molecules, and we introduce one linkers. Obviously the previous one is a Chinese patent. Obviously it's very difficult. Obviously with the patent you can sell to the hospitals, and so we started working on another PSMA molecules so that we can have a different structures, so we can produce it at our pinstrick, and we can supply this to the medical centers. So we using the same methodology, solid phase peptide synthesis, and we finally come up with these molecules. Obviously here if you see the structure is a urea lysine molecule. However, here is we introduce this benzyl group as a linkers, as a lipophilic type of linkers, and obviously this is a chelator. So only difference with this molecule, the previous molecule, we introduced this lipophilic linker here to fit into the pocket, the lipophilic pocket of the PSMA. And then we obviously purification, characterizations we performs. It's look very simple here, but obviously we need to pass into the various step and finally getting into this compound. And then we did perform the radio labeling and quality control studies, and obviously show very good radio labeling efficiency of more than 99%. We check with the radio HPLC as well. It show very good single peak into the HPLC. And we study the effect of the different factors, such as effect of reducing agent, effect of activity on the radio labeling efficiency, effect of incubation time. We did the optimizations at what time and what activity and amount of stannous chloride. The kits show very high radio labeling efficiency. And then we check the stability as well. It show very high stability until 250 minutes in normal saline as well as human serum albumin. And then we did actually, I didn't show it here, preclinical study into the mice to check the toxicity as well as normal distribution. Obviously one thing we lacking here, that we don't have immunodepressant or skewed mice or bulb nude mice. So that we can inoculate any tumor into that, and then we perform the SPECT-CT to check that it show uptake here. And also the other limitation, because we don't have a cell line as well. So in vitro study would not be actually possible at our institute for the time being. So we did it in the normal mice only, and then we perform one case and we prepared this kit and we sent it to the Nuri. They did one patient, and this kit show very good profile compared to the previous one. It show very good uptake into the lacrimal gland. If you see here, this prostate cancer lesion is very prominent here, very high intense uptake. So this PSMA molecule might be a good candidate for the monitoring or staging the cancer in the prostate cancer patients. So in the conclusion, we have synthesized technetium PSMA conjugates as well as a lyophilized kit for the easy preparation of this radiopharmaceutical at the radio pharmaceutical hospital radiopharmacy. And obviously this PSMA imaging can be used for the monitoring the progression, treatment response, leading to the more effective treatment option for the patient with the prostate cancer. And obviously still there are a lot of work to be done with this, obviously to compare it with the other like gallium based PSMA molecules, to check the diagnostic accuracy of these technetium PSMA molecules. And obviously we have a plan in the future to compare it with the other gallium PSMA molecules as well. And at the end, I would like to thanks to the all who provided the support for the development of this kit and radioisotopes, especially to Dr. Wasim here sitting here, is so encouraging for the development of this all the project. And at the end, I would like to thanks to the Professor Yun Sing Lee, who is sitting here. He is a mentor to me as well and a good friend of mine. So I would like to thanks to him, and the other one, the personality here, Professor Jaemin Jong, who retired. He is also mentor and a very good professor when I was there in the Korea doing my PhD. So at the end, I would like to say Kamsahamnida. Thank you very much. Thank you.
Thank you, Dr. Nadeem, for a very good presentation and showing the data from local peptide synthesis kits. If there is any question, please. Yes.
Nice presentation, but it looks that it's very simple here that you take one drug to the patient right away, because you have to go through so many steps, international guidelines, before you can use your drug into patient. And I'm not very convinced, I'm not saying that, but the data you are showing that it is not FDA approved, GMP conditions, so all these guidelines, you know, to make sure, and then you need IND from your physician that is safe, you know. So I think one has to consider all these factors before they can use in clinical testing. Thank you.
Okay, thank you very much. I was expecting this question actually. So actually we got the consent of the patient as well as ethical review board approval. And as I told, I didn't actually, as I told previously, that we don't have a cell line obviously. That is, we are lacking here currently in Pakistan. We are trying our best to develop this type of things here as well. And obviously, you need to check the affinity of that radiopharmaceuticals. So you need cell lines or animal models. And currently, we don't have these both. You're right, absolutely. We need to check all these. And obviously, we have the lab here. Because we are producing the radiopharmaceutical kits GMP based at our facility as the Pinsticks, so we maintain all of the other criteria associated with all these things. The things which we are lacking, obviously the cell line study and as well as animal world. But we perform in the normal, as I told, we perform to check the toxicity as well as the distribution profile of these before going into the patients. And for the patient, we take the concerns as well as RIB approval in this case. Thank you.
Any other question? So, if there are not any further questions, we thank our speaker, Dr. Nadeem.
Thank you. Thank you.
And last presentation of this session is by Muhammad Shahid. He is our colleague from PNRA. Muhammad Shahid has about has got his research is an internal dosimetry and production of medical radioisotopes through charged particle reactors. He has participated in many national and international conferences. He has over 30 publications and supervising about 18 masters and PhD students. Topic of his presentation is internal dosimetry for patients, protection and regulatory framework. Dr. Shahid, please.
Thank you very much, sir, for a nice introduction. And I'm thankful to the Pakistan Nuclear Society of Nuclear Medicine for giving me a chance to present this work. This work is very important because here was much more discussion about the resolution of the image, about the dose of the patient, about the production of the pharmaceutical. So I have tried my best to present whatever we did in the investigation of the internal dose of the patients in the different scans. So I will present it in the upcoming slides. For those who are from abroad and those who are not familiar with PNRA, I would like to introduce my organization, that Pakistan Nuclear Regulatory Authority has the mission to protect the workers and the public from the harmful effects of ionizing radiation. And we have different offices in Pakistan, and our task is to ensure that all the practices are according to the international standards that are set for the use of radiopharmaceuticals, as well as the other practices that are related with radiology and radiotherapy as well. We have headquarters that is located in Islamabad, and we have other regional offices. So if you see the regulations that are established, that are the laws that are available in Pakistan, according to the laws, no patient undergoes a radiological procedure unless prescribed by a medical professional. So this clearly describes the responsibility of the nuclear physicians as well as the oncologists who are responsible to prescribe the dose. The patient or the patient's legal authorized representative has been informed as appropriate of the expected benefits of the radiological procedure as well as the radiation risk. So the risk associated with any kind of scan or treatment is also important to investigate, because you are legally authorized to inform it to the other persons and share this information with the colleagues as well. Medical professionals are responsible for ensuring overall patient protection, so that's why it's also related with the internal dosimetry. So with these laws, I would like to tell you that these investigations are important, particularly the internal dosimetry that is given in the different laws, to see that what risks are associated with the doses. So why internal dosimetry is important? Because it is to assess the patient's dose as well as define guidance reference levels to permit the use of new radiopharmaceuticals, like Dr. Nadeem Lodhi was sharing his study. So it's important to undergo through these procedures to, if you are interested to apply on the patient scans. And this study is also to plan radionuclides dose, that is therapeutic dose that was in theranostic procedures or the other procedures like the radioiodine. And it is also important to set the investigation levels and decide the discharge limits in case of iodine therapy and other things. And to determine the dose in the accidental situation and measure the dose due to radio contaminants or impurities, and develop the regulatory working guidelines procedures, and to define patient's discharge limit in other procedures as well. Like there are new radioisotopes that are used for the therapy, like actinium-225 and other radionuclides that are in the market for radiotherapy. So discharge limits can be defined with the investigation of internal dosimetry. So this is the basic of internal dosimetry. You know that when radioactive molecules or the radiopharmaceuticals are injected to the patients, different organs are become radioactive and they are scanned with the gamma camera, and we can, with this study, we can understand that what is the dose to the source organ as well as source to the target organ, and from this we can investigate that what is the dose to the healthy tissue as well as to the target organs. So this is the very simple basic information. So if we are interested to investigate that how this study is carried out for those who are new in this field, I would like to say that the first three parameters are related with the physics, while the fourth parameter is related with the biology, that is the biokinetics of the patients, and this is more related with the investigation of the residence time, that is given with the tau as a symbol. So in this one we investigate that what is the dose to the target organ as well as to the source organ, and the residence time is calculated like as is given in this picture. You see that time versus the activity. In this procedure we investigate that what is the flow of the activity at different times. So according to these equations we can then see that how the activity is flowing from one organ to the others and vice versa. And because of this we can understand the metabolism, distribution, uptake and excretion of that activity from the body. And these are the simple equations that are used for the determination of S value, and S value is related with the radionuclide that is injected to the body, whether it is a gallium or yttrium-90 or any other radionuclide like technetium. And we calculate the dose, and there are different parameters that are used for calculations. So this is just the sharing of data, that is you see that here was lot of discussion, so I just included one slide last night. So, for example, this is because of the dosimetry procedures that they are giving the comparison that if yttrium dotatate or lutetium dotatate is injected to the patient, how much dose is given to the is received by the different organs by the patient. For example, in the red marrow, you can compare the dose and kidneys as well as liver. So you can estimate the risk to the different organs. So nuclear physicians are definitely interested in the image, but they are also interested with the dose that is imparted to the different organs of the patient. So keeping in view the patient dose, the physicians are free to decide that which radionuclide is better for this investigation. For example, if you compare the injection of thallium-201 as with the technetium-99 cis-TAMIBI, you can see that 74 megabecquerel or 2 millicurie dose is given in thallium chloride, but overall the dose to the patient is received is 40 millisievert by the thyroid and 30 millisievert to the kidneys. Whereas 740 megabecquerel dose is given to the patient in the technetium scan, and gallbladder receives only 29 millisievert while the kidneys receive 27 millisievert. Overall dose is 11.5 millisievert in thallium chloride and 6.7 millisievert respectively. The effective dose for thallium is 11.5 millisievert, whereas for technetium is 6.7 millisievert. So you see that it is almost half of that is given in the case of thallium. And in case of thallium scan, the thyroid was on risk, whereas in the technetium scan, the dose is not received by the thyroid. So this is important to understand by the physicians to decide that which radioisotope should be implanted, should be used for different procedures. For example, in this study you see that they have carried out investigation with sodium iodide 131, 123 and technetium oxide and maybe and FDG. So you can compare, here is the comparison that shows clearly that how much dose is received in that procedure. So this information is usually very informative for the nuclear physicians to decide the use. So here from this slide I would like to share that what investigation we did carry out. So you see that there are different procedures that are used for the investigation of dose. For internal dosimetry we can carry out studies on the animals, as well as we can also carry out the study with the help of scintillation camera, that is SPECT camera. I carried out in the studies with both procedures, but in the first one that study was carried out in Brazil with the help of a professor. His lab was dedicated to carry out the animal studies, and in this study we injected the gold nanoparticles, as well as in the other study we injected graphene to the mouse, and then we investigated that how much dose was distributed in the different organs. For example, in one study I would like to share that gold nanoparticles were obtained through the nuclear reactions, and then those were injected in the patient in the mouse, and then it was observed that how much cell killing is over there that are the cancerous in the mouse. The cancer was grown in the mouse. In the studies that are carried out in Pakistan, we have these steps that were followed in Pakistan, and here you see that the first step was the patient preparation, and then patient was taken to the gamma cameras for scanning, and the scans were obtained, and those scans were then further region of interest were marked, and counts per pixel were calculated, and then according to the different models that are available in Olinda and IDEC those models were used, and then those to the different organs were measured. For example, in case of neuroendocrine tumors that was carried out in Uri, in this one the different scans were carried out, like see that here the first scan was at half an hour post injection, and then the second scan was around after 2 hours, and the third scan was after 4 hours, and so on. And from this study we observed that the dose to the different organs for different scans was like this. These are the mean dose for example, you see that this is the study with Olinda, and that was the dose in the male patients, whereas there is also the dose for the female patients. And the organs that received the dose was liver, spleen, kidneys, bladder, and there was effective dose that is in millisievert per becquerel. So you see the results that these are the results that are given in comparison with the ICRP recommendations. You see that the procedures followed by the hospital are in agreement with the prescribed limits by ICRP. So in this procedure, the kidneys received 0.024 milligray dose per megabecquerel, whereas spleen received 0.029 milligray per megabecquerel. And likewise, the effective dose was 2 millisievert in this scan. In the case of DMSA studies, that is the renal scan study, again the same procedure was followed and different scans were taken at different times. And after investigation, we came to know that the dose received by the patients, the 10 patients were scanned and the dose received by them was well below the prescribed limit by the ICRP. So you see that here in this graph, the green are the calculations that were carried out with the help of Olinda, whereas blue are the doses that were calculated with the help of IDEC dose software. Likewise, in this scan, you can see that the activity versus the organs at risk, these are carried out over here, and they show that the dose received by kidneys was 69 microsievert per megabecquerel, whereas the liver was receiving 6 microsievert per megabecquerel. Likewise, in the case of tetraphosphamine, this study was carried out, and again different patients were scanned, and here I am going to share the scans of the patient that were taken and see that the dose received by them is given in this table. So here the organs are brain, colon wall, gallbladder. Mostly the dose was received by the heart valve, kidneys and the livers. These are the organs that received maximum dose, and these are the patient data, whereas this is the prescribed dose limit that is given in this table. The effective dose is also, the graph show that the prescribed dose is above, whereas the received dose is below the prescription of ICRP. Again, in case of Sestamib, the patient scans are over here, and we carried out the study, and you see that the dose received by the patient is also below the prescribed limits. And this study is still not complete, and it is under still publication, and we will share it with you later on. And I am thankful to those who helped in this investigation, and particularly Dr. Shazia, who was at that time in charge in nuclear medicine department of Noori. She supported me to carry out this study, and I am also thankful to Dr. Adnan. He also supports me. And the students were from Comsets University and UT Texla. I am thankful to everyone. Thank you for your patience.
Thanks a lot, Dr. Muhammad Shahid, for a presentation on dosimetry aspects of radiopharmaceuticals. If there is any question, please because we have very short time, just time for one quick question.
Very nice presentation. Do we have Olinda software or this type to be used for the dosimetry here in Pakistan?
Yes, Olinda software is available. I got it with the support of someone, but it's available with me, and you can get it and use it.
Okay, thank you very much.
Any other question?
Any other question? Okay, if there are not further questions, we thank our speaker once again, Dr. Muhammad Shahid. Now I have been told by the organizers that yesterday online presentation was skipped. Now there is a time for the last presentation of this session, and it is actually from yesterday. It is clinical applications of FDG and non-FDG tracers in oncology, a tool for theranostics. Our speaker is Dr. Gopinath from United Kingdom. Please.
Firstly, I would like to thank the organizers for this kind invitation to talk at this forum. My topic for today is about FDG and non-FDG tracers, and I will just brief you about the common facts about these tracers and their clinical use. For the next 20 minutes, I will take you through the tracers, the clinical applications, cost and availability, and what are the common challenges to bring these tracers for common use in our departments. In fact, approximately about 40 million nuclear medicine procedures are performed worldwide every year, and the demand for the radiopharmaceuticals are increasing at an annual rate of approximately about 5%. And over 10,000 hospitals use radiopharmaceuticals, and approximately 90% of these are for diagnostic use. The suppliers vary from region to region, and I'm not going into detail into this topic. And coming to the Imagine, which is an IAEA nuclear medicine global resource database, it's a good article to read to look at the domain of nuclear medicine. And in fact, approximately about 27 SPECT and SPECT-CT systems are installed in about 140 countries. And about over 5,000 systems have been installed in 109 countries, which have PET-CT capability. Coming to the PET pharmaceuticals, which is the topic for today, in fact, you can broadly classify them based on their radionuclides into fluorine-based or carbon-based or iodine-based or gallium-labeled agents. And they all look at various aspects of cell and cell metabolism in terms of glucose metabolism, bone metabolism, and receptor imaging such as somatostatin receptors, prostate-specific. And we also can look about angiogenesis, and hypoxia, apoptosis, protein synthesis, etc. And you can really use these agents to the full potential to assess the clinical aspects of oncology. Coming to a flashback, you need to know about FDG before we go on to the tracers. It is one of the commonest tracers used in the world of oncology, and the story goes back to 1976, which was originally synthesized in Brookhaven Laboratory by Alfred Wolf and Joanna Fowler, and later it was modified to use clinically in a better way by Hamacher and Stocklin. And in fact, it was Tatsuo Edo who first synthesized FDG, and it was taken in a special plane to University of Pennsylvania, where the first FDG brain images were acquired in a Mark IV scanner. And currently, approximately about 2 million FDG PET-CT, or maybe more than 2 million FDG PET-CTs are performed annually worldwide. Coming to the clinical applications of FDG, we all know that it's used to assess and differentiate benign and malignant lesions, look for unknown primaries, staging, restaging, and to look for the best site for biopsy, detecting tumor recurrence, and of course for radiotherapy planning. Coming to FDG, it is an analog of glucose. It enters the cell using glucose transporters. It is phosphorylated and cannot be metabolized further. It is often administered as intravenous injection. Injected activity is approximately about 185 to 370 megabecquerels. Half-life is about 110 minutes. Ideally, we expect the glucose level to be less than 10 millimoles before injecting the radiotracer. The reason is the patient preparation plays an important role to get the optimal results for interpretation of these scans. And the organ receiving the highest dose is urinary bladder, and the oncological and non-oncological indications are multiple. And the effective dose is approximately about 5 to 8 millisieverts. Coming to choline, choline came in as a Big Bang tracer, as an useful tracer. In fact, in 2001, they have used and evaluated fluorine labeled choline as an oncological tracer. In fact, it was came in as an alternative for FDG. And basically, it runs to the principle of phospholipid synthesis. And it played a significant role in prostate imaging. But unfortunately, at the same time, PSMA came into the market, and therefore, the role of choline was totally wiped out. But currently, choline can be used in various oncological conditions like brain tumors, lung cancer, esophageal cancer, colon, prostate, and bladder. But currently, I think so it's got some role, and most centers who use choline use it for parathyroid imaging. And in prostate cancer, in fact, it had a useful way of changing the management in approximately about 50% of patients. As I told before, with the advent of PSMA and other tracers, the role of choline, which played an important role in prostate cancer, is totally wiped out. And the effective dose is approximately about 6 to 7 millisieverts. Then coming to sodium fluoride, it is another interesting tracer which is not commonly used due to cost implications and availability. And in fact, the story goes back to 1960. It is one of the oldest radiopharmaceuticals used for bone imaging. In 1972, the FDA approves it and they withdraw it in 1975. And that is the time when SPECT tracers like MDP came into existence. And in 1993, it was back in clinical use in some centers. And in fact, FDA approves or reapproves in 2000. And the role of NAF is it deposits on the bone via chemiabsorption. It's got better pharmacokinetics, there's no doubt about it. It's got a faster clearance from blood. It's got a higher uptake in the bones, minimal protein binding, high fast extraction, and it has got a fast soft tissue clearance. And images can be obtained as early as about 30 minutes post-injection. In fact, 50% of the radiotracer is taken up by the bones immediately after the injection. So radiation dose is comparable to the conventional technetium labeled bone scans. And in fact, when you compare to the conventional bone scans, the NAF has better image quality because of better spatial resolution, higher target to background ratio, and higher overall sensitivity in lesion detection. And effective dose is approximately 4.3. But again, if you are comparing conventional bone scan with NAF, you need to be quite careful. If you're going to compare with a planar bone scan with NAF, NAF will definitely be better. But if you're using a whole body SPECT CT and compare it with NAF, it's more or less, in terms of sensitivity and specificity and lesion detection, it's more or less similar. But one thing, the NAF has a better image quality and it is really spectacular to look at when you compare to a conventional bone scan. Coming to gallium DOTA, in fact, it is one of the commonest and the most important radiotracer used in the world of neuroendocrine tumors. Initially, historically, in 1987, it was labeled with iodine-123 and later on with indium. And in 2016, the European Medicines Agency and in 2019, FDA approves gallium DOTA for clinical use in neuroendocrine tumors. And various types like DOTA-TATE and DOTA-NOC and DOTA-TOC. But if you want to compare between DOTA-TATE and DOTA-TOC, DOTA-TOC has got high affinity for somatostatin receptor 2 and lower affinities for somatostatin receptor 5 and 3. And in DOTA-TATE, it's got a 6 to 9-fold higher affinity for somatostatin receptor 2, no affinity for somatostatin receptor 5 or 3. And the Society of Nuclear Medicine implemented the appropriate use criteria. So if you want to use gallium DOTA-TATE in your conventional imaging, it is used for initial diagnosis after histological confirmation. It is used to assess known metastatic disease, or you have to find out the unknown primary, selection of patients for PRRT, staging before surgery, mass suggestive of NET but not amenable to biopsy, and therefore you can assess the site of biopsy, monitoring neuroendocrine scenes predominantly on somatostatin receptor PET. So in terms of diagnostic performance of these two common tracers, DOTA-TOC has got a sensitivity of approximately 93% and specificity of 85. DOTA-TATE has got a slightly better specificity over reaching 100%. And if you want to compare your conventional SPECT tracer with gallium DOTA-TATE, definitely the gallium-based tracer has got a superior quality, a short half-life of 68 hours, and image quality is definitely better. and lower radiation dose and excellent target to band ratio. Then you might ask me a question like, what's the difference between a SPECT and a PET tracer in this clinical context? But if you're using indium-based or a technetium-based SPECT tracer to image neuroendocrine tumors, in comparison to gallium DOTA, you'll be missing approximately about 25 to 30% of lesions. The smaller lesions are not clearly visualized on SPECT imaging due to the resolution, but gallium definitely has a better diagnostic performance in comparison to the conventional SPECT tracers. And the selecting patients for PRRT is based on Krenning score. Again, it is based on the planar imaging, looking at the uptake in relation to the liver and spleen. But what is interesting is there's another article which has come from the Australian group. It is a must-read article from Chan et al. It is published in Theragnostics in terms of a novel grading scheme with prognostic significance. They use FDG and gallium DOTA in grading these patients from P0 to P5, which has got clinical and prognostic implications. In fact, the effective dose is approximately about 4 to 6.4, depending on the tracers you use. Coming to the most talked tracer, gallium fluorine labeled PSMA. It's a type 1 transmembrane glycoprotein, often overexpressed in prostate cells. And in fact, the expression is significantly higher in advanced stages and also in castrate-resistant prostate, approximately about 100 to 1,000 times. PSMA is not only related to prostate cancer, it's not only expressed in prostate, it's also expressed in a range of tissues and several benign and malignant processes. So that has to be taken into consideration when you are reviewing gallium or fluorine-based prostate-specific membrane antigen scans. What are the advantages? Is the detection rate is definitely better. You can, the nodal metastasis detection is not limited by the size criteria. Detection of primary local recurrence nodal disease is exceptional, there's no doubt about it. You can assess even the treatment response. It's still evolving, but there's no clear-cut criteria, but still it is useful in assessment of treatment response. And it's often problem solving in terms of staging and also change in management plans. And higher detection rate is even seen in patients with lower PSA range. And the specificity is approximately about 92% in localization, and for nodal staging it is about 99% with a sensitivity of around 66%. Detection of bone metastasis is definitely better compared to conventional bone scans with a specificity of 99 to 100%. And in terms of assessment of relapse, it's got an overall detection rate of approximately 90%. And the effective dose, if you're injecting around 200 microbacterels, it is approximately around 5 millisievert. And then coming to another interesting tracer, again backtracked or shadowed by PSMA, is a fluorine-based fluciclovine, which is basically an amino acid transport mechanism because it takes advantage of increased amino acid transporters in prostate cancers. It was approved for prostate cancer imaging by FDA in 2016, and in fact, it is due to its rapid influx and efflux of amino acids, the pathological activity in the prostate tumors and as well as in metastatic sites peaks around 4 to 10 minutes after injection, and therefore you can scan the patient as early as possible. And also there is minimal or no activity exuded in the urine, but sometimes you can get some low-grade activity in the bladder, but that rarely interferes with image interpretation. And based on the uptake, we have you can broadly classify them as mild, moderate, and intense uptake, depending if it's called mild, if the avidity of the tracer is equal to or greater than that of the blood pool, but lesser than the bone marrow. And if it is greater than the bone marrow and less than the liver, it's moderate. And if it is equal or greater than the liver, it is called as an intense uptake. And in fact, as I said before, you can image the patient in approximately 3 to 5 minutes post-injection. And the performance for assessment of prostatic bed specificity is slightly lower, but it's got a higher sensitivity. And in terms of extraprostatic, the specificity is higher, about 97%, and sensitivity is approximately about 55%. And it's also used for non-prostate indications, like, for example, in brain tumors and gliomas and meningiomas. And it is an interesting tracer, but unfortunately, it took a backtrack after the PSMA, but still it is one of the approved radio tracers for imaging prostate cancer in the United States. Coming to another interesting tracer, which has been branded as the radio tracer of the century. As you know, the tumors are a combination of malignant cells as well as stromal cells. Stromal cells, what are stromal cells? There's nothing but vascular cells, inflammatory cells, and fibroblasts. And in fact, stromal cells might contribute to more than 90% of the tumor mass in tumors with a desmoplastic reaction. So, for example, breast cancers and colon and pancreatic cancers. And then you might ask me a question that are fibroblast activation proteins expressed in all fibroblasts? The answer is no. FAP is highly expressed on cell surface of activated fibroblasts, but not on resting fibroblasts. Does activated fibroblasts occur only in tumors? The answer is again no. It is seen in healing wounds, disease with matrix remodeling, inflammation, infarctions, and fibrosis. And what is interesting is if FAP is more specific than FDG, that's a common question people will ask, because the reason is this going to replace or it is going to be a challenge to FDG imaging in the future? The answer is no. The reason is the tracer is taken up by post-surgical wound healing due to activation of fibroblast, and also FDG accumulates in acute inflammation and FAPI accumulates in typical for chronic inflammation. So again, this is a non-specific agent. It goes to cancer cells and as well as inflammatory and infective pathologies. But how we are going to market this and how we are going to make it as a challenge is how is and why is FAPI more attractive? The reason is it's got a very fast tracer kinetics. You can image the patient in less than 1 hour. The beauty is it's got a low background activity in the liver, therefore you can detect more liver lesions, and also low background activity in the oral mucosa and brain, so you can detect brain lesions. And the most important, which I like, is about independent of blood sugar levels, and therefore you don't have to concentrate more about patient preparation in terms of glucose levels and other factors. And if a tumor expresses FAP, and what is the implication? In fact, overexpression is associated with worse prognosis. And how soon after injecting of radio-labeled FAPI you can image the patients. In fact, because of the rapid tumor uptake, at 10 minutes post-injection, you can image as soon as possible. Maybe 15 minutes post-injection, you can start imaging these patients. So this is the tracer to watch for, but still it has not gained that much of prominence in comparison to PSMA. But there are quite excellent papers on FAPI in the literature, looking in terms of about 28 cancer types, and they're given pros and cons in each cancer types, and it's a good article to read, or the good article to start with. But only problem here is, again, there are different types of FAPIs now that causes real confusion, which is which type of FAPI you want to use. And that is, again, it is one of the self-goals nuclear medicine often scores in the evolution of specialty. Finally, coming to GLP-1, this is again a very interesting tracer. This is a radio-labeled glucagon-like peptide, commonly used in assessing patients to localize insulinomas. It's quite expensive, and that's the reason it is not made effectively in the market, but there are a few centers looking in terms of using this specifically when most of the tests are equivocal or failed. GLP imaging can help in detecting and localizing insulinomas. Compared to endoscopic ultrasound, which has got a sensitivity approximately about 84%, the gallium-based GLP has got a sensitivity of approximately about 98%. In fact, the European Neuroendocrine Tumors recommends using this tracer or selective intraarterial calcium stimulation if you have a negative contrast enhanced MRI or CT or a negative endoscopic ultrasound. And this is the tracer of choice to localize insulinomas. And coming to the last few slides in my presentation, there are quite a lot of common theranostics pairs in nuclear oncology. In fact, the newer tracers are exploding in the world of oncology, especially in therapy, with the advent of a lot of alpha tracers coming into the market and beta tracers. And it is a great time for nuclear medicine. In fact, it should be called as an industrial revolution of nuclear medicine. But how we are going to use this time is very challenging, and the most important hurdle will be cost implications. So more and more people will be thinking of tracers labeled with SPECT tracers will be a major area to look for an alternative to PET tracers. And what are the common challenges is it's a global issue in terms of how does it impact. The most common question is always there is a shortage or limitations in availability of kits, and the problem in the supply chain, the regulatory aspects, and who's going to pay for it, and the challenging in training these people, and workforce limitations will play a significant role. But we need to address as a community, as a society, we need to have a specific special interest groups to look into terms of how you can use and bring these common radiopharmaceuticals into clinical use, either as a SPECT tracers or as a PET tracer, so that the patients can benefit into most. But again, you need to have a very structured investigating algorithm, and therefore you can use them effectively and specifically rather than haphazardly using it, initially calling it as a specific tracer, and later it turns out to be a very non-specific tracer. Therefore, you have to be quite careful. So to conclude my presentation, nuclear medicine procedures are widely used and is expanding worldwide, there's no doubt about it. Clinical use and acceptance is on the rise. Access and availability of diagnostic and therapeutic radiopharmaceuticals is vital. And moreover, you need to have patient outcome data and also cost-effective analysis to convince people paying for these procedures so that we can use these tracers effectively and which might benefit our patients. I would like to thank my mentors, and finally, once again, thank you to the organizers for this kind of invitation. Hope to see you all sometime in Pakistan. Thank you very much.
Thanks a lot, Dr. Gopinath, for a very clear presentation on the clinical aspects of FDG and non-FDG tracers in oncology. I am sure there would be one or two questions from the audience, please. So, if there are no questions, we once again thank to our three speaker, and with this, I hand over the system to our chairperson, Dr. Muhammad Wasim, for closing remarks.
Thank you, Dr. Irfanullah. So this was the sixth session, scientific session of today's conference. There were 5 talks in this session, and those talks were wonderful. I'm thankful to all presenters, and I'm thankful to all participants for listening these talks very carefully and with interest. The first talk was by Dr. Yansung Lee. He discussed the application of radio nanomaterials, medicines for theranostic purposes. He explained the application of nanomaterials in radiopharmaceuticals, presented methods, how to prepare and how to label nanoparticles with different radioisotopes. And then he presented a case of labeling iron oxide nanoparticles with NOTA and gallium-68, and then presented its results. The second talk was presented by Dr. Subhani. His talk was about the use of peptide-based radiopharmaceuticals. He explained why peptides are used in radiopharmaceuticals, their selection criteria, and how to design these peptides to be useful in as a radiopharmaceuticals. He showed some results of rhodamine labeled with copper-64 and explained the production of gallium-68 and lutetium-77 kit with PSMA. He also presented some results of zirconium-89. The third talk was delivered by Dr. Nadeem Lodi. He explained the preparation of PSMA in a lab and its labeling method with the technetium-99M. He also explained the method of its preparation, purification, characterization, and final step of quality control. The fourth talk was delivered by Dr. Muhammad Shahid. He explained and discussed the internal dosimetry for patients and presented the regulatory aspects of internal dosimetry. He also compared results of different techniques and doses delivered to patients with the IEEA limits. The last talk was delivered by Dr. Gopinath. He discussed the clinical application of FDGA and non-FDGA tracers in oncology. He presented other tracers such as choline, sodium fluoride, DOTA with gallium-68, PSMA with gallium and fluorine-18, FAPI, GLP-1, and others. So that's it. Thank you very much for listening.
Thank you very much, Dr. Wasim, for the closing remarks. Now it is time for the distribution of shields and certificates. I request Dr. Shazia Fatma to please come on the stage and distribute the shields and certificates among the speakers. Our first speaker is Professor Yang Sung Lee from Korea. Please come for the shield and certificate. Professor Shubhani Ukarvi, please. Dr. Nadeem Ahmed Lodi, please come on the stage. Dr. Muhammad Shahid from PNRA. Dr. Muhammad Wasim, a chairperson of the session. Dr. Muhammad Nadeem, co-chairperson of the session. And at the end, me as the moderator.
Thank you so much, everyone. With this, we come to our last order of the business, that is towards the closing ceremony of this conference. And there are a few rewards that we have to give out for the free poster and free papers. Madam, I would request you and Dr. Azra, आप लोग please stage पे आ जाएं to give these awards. So for the category of posters, I will call out the names and please do come on the stage. For there's no 1, 2, 3, first, second, third in the poster category. It's the top 3 posters across the category. We have shields and special price, cash prize for these. Dr. Kiran Bisharat. She is not here. Dr. Hafsa. She also is not here. Dr. Anam. Okay, on the recommendations of our worthy evaluators, there is something that I think hasn't been done before. We are specially honoring for all the submissions that have been presented yesterday. So I'll call upon all of these and please come and collect cash prize for yourself. Dr. Mariha. This was a strong recommendation that we should start encouraging all of these young investigators. So this is something that the suggestion was liked by the EC and we are honoring that suggestion. Dr. Mariam. Dr. Bushra. Dr. Nayab. Dr. Sabine Zia, Mr. Saleen Khan, Mr. Kamar Zia, Dr. Noreen Nizar, Mr. Irfan Ali. And again, on the special note for the feedback that we got, there is a special cash prize and the shield for a special individual. This was a poster that he presented, was very much liked by the evaluator, and it is to encourage the individuals who are working in that capacity. One of the technologists from Noori, he will be receiving a special cash prize and shield in this. Mr. Fahim, if he is here, or someone can collect on his behalf. Maybe Dr. Adnan is here. Okay, you can come and collect, no problem. No, Dr. Adnan aa jaye. And there was a special recommendation by the evaluators that you should keep on doing that and try to publish it somewhere. Okay, the second part, now we'll move on to the paper section. Again, we have 3, these are again I would say, this no order of 1, 2 or 3, these are top 3 papers that will be presented with the shield and the cash prize. So first I will announce Dr. Zishan from Afiri. AFIP? Sorry, AFIP. Dr. Hamid Shabir. And the third one would be Dr. Tania Jabbar. And now continuing with the same tradition that we did in the free poster, all the presenters today, they will also get a special cash prize for their presentations. Dr. Sajid Bashir, and I must say it was a wonderful presentation. The time slot was very short for his presentation, but it was a very novel direction that he is giving, like working with the basics of artificial intelligence. It was a wonderful presentation, Dr. Saab. Followed by Dr. Wajiha. Dr. Hasnan Dilawar. Dr. Khalida. Dr. Farzeen Zahra. Mr. Zishan Hamid. I didn't attend this one, but I think it should be a very promising, because it's against his AI-assisted diagnosis of metastasis in whole body, something that it will be, I think, the talk of the town in another 3 or 4 years maximum. He's not here? Okay. I hope I haven't missed anyone. Koi reh to nahi gaya na? Okay. With this, oh yes, we have the evaluators. Sorry, evaluators. So for the 2 moderators that we had, and they were the evaluator also, Dr. Amir Bahadur. He is not here. Dr. Sadiq Nahario. No, for Dr. Amir Bahadur, Dr. Akifullah will be receiving. For Dr. Sadiq Nahario, anyone from his center if he's not here? Oh, he's here. And these 2 individuals are also the evaluator for this session. Dr. Javed Irfan. Where is he? Oh yes, here he is. So we had 2 additional evaluators also. I've just named them. Dr. Baba Imran was part of that committee, and Dr. Durre Sabi was also a part of that committee. And last one, Dr. Awais, if you can also come on stage. And with this, we come to end of this award ceremony, and I would like to request Dr. Shazia Fatma to just come and with for her vote of thanks. Closing of.
Assalamu alaikum, and I think it is already good afternoon, and we were supposed to finish before 12, but due to the usual delays, we are ending up an hour late. Anyway, 3 days were full of academic activities and meeting up and greeting up and everything, and I hope in last 3 days you learned what you already have knowledge of, but you relearned from our speakers, our faculty. So we are very thankful to all our international and national speakers who contributed to make this conference a real rainbow of nuclear medicine knowledge. And also, we are thankful to all the young contributors, because the sessions of the free paper poster sessions and also the poster session, they were very much appreciated by our assessor, and we were told that we should encourage our younger generation, and even in our discussions, and our GBM people were talking about encouraging the youth of nuclear medicine, because that's the future of nuclear medicine in Pakistan. So perhaps we will have more free sessions, and probably we were pressed with time, but we would have brought the better papers in the academic talk. Anyway, we are thankful to our contributors nationally, internationally, young investigators. Industry partners, because without their support, it was not possible to hold the conference of this caliber. And then in industry, I should thank the management of Pearl Continental Hotel, because they were with us for last few months on for last 2 days, but today I don't know what happened. It was the coming and going of electricity and all that. So anyway, we are thankful for our audience who attended this conference and made it a success, because अगर आप लोग नहीं बैठे होते तो सोफों ने तो सुनना नहीं था, तो इसलिए आपका होना बड़ा ज़रूरी था. और academically, I hope you learned from whatever we were able to present in front of you. In addition to that, किसी ने कुछ बोला था, I thought कि मुझे कुछ कहा. Last but not the least, my executive council, and I cannot name कि किसने कितना काम किया है, but one man stands out, और डॉक्टर इनाम है. जो चीज़ हमारे लिए प्रॉब्लम होती थी वो डॉक्टर इनाम सॉल्व करते थे. And if I am not wrong, this conference is 90% what he did, and only 10% was the contribution of all rest of us, because he was anchored over here, and इनकी support के लिए जो डॉक्टर मेहती और ये जो इनकी सारी टीम थी, इन लोगों ने बहुत हमारी हेल्प की है, और सारा जो ऑर्गेनाइजेशन है उनकी वजह से ये पॉसिबल हुई है. एंड आई एम सो थैंकफुल टू ऑल ऑफ देम जिन्होंने डॉक्टर इनाम को सपोर्ट किया, और डॉक्टर इनाम के लिए एक स्पेशल थैंक यू. Lastly, we had few new things in this conference, which you all know that we had a leadership symposium in the first on the first day. Or we decided in that leadership symposium that instead of having a conference after 2 years, we will have annually. And one will be the international one, the next one will be the national symposium or conference. So with consensus, I hope Dr. Babar मुझे नज़र नहीं आ रहे यहाँ पे, लेकिन हमने ये डिसाइड किया है कि नेक्स्ट कॉन्फ्रेंस जो है वो फैसलाबाद में होएगी, और एग्जैक्ट डेट वी विल कम्युनिकेट, लेकिन नवंबर के फर्स्ट और सेकंड वीक में फैसलाबाद में वी आर गोइंग टू हैव अ नेशनल एनुअल कॉन्फ्रेंस ऑफ न्यूक्लियर मेडिसिन विच विल बी द 9th वन. और इसके अलावा जो है एक हमारी जो एफर्ट थी कि हमने डिबेट्स का वो शुरू किया है, तो आई होप कि यू एंजॉयड दैट, और उसमें हम और इससे आगे जाएंगे. वन थिंग इज़ फॉर द मेंबर्स कि हम लोग एफर्ट करते हैं, हम आप लोगों को टाइमली बताने की कोशिश करते हैं. वी हैड फीडबैक्स कि हमारी वेबसाइट अच्छी नहीं है, जिसको हम इम्प्रूव करने की कोशिश कर रहे हैं. बट वट एवर यू गेट ऑन emails, प्लीज़ उसको रिस्पॉन्ड किया करें. वी आर नॉट सेंडिंग थिंग्स इन स्पेस के जो वापस नहीं आती. हमें ये लगता है कि किसी के पास कुछ पहुंच नहीं रहा है. एंड व्हेन वी कॉल पीपल एंड टेल देम टू चेक देयर स्पैम और चेक देयर ईमेल्स, देन कुछ लोगों ने रिस्पॉन्ड किया. तो काइंडली ये ज़रूर किया करें, क्योंकि आप हैं तो हम हैं, और अगर आप नहीं हमें सपोर्ट करेंगे और आप हमारे साथ नहीं होंगे तो ये काउंसिल और ये जो PSNM है, इट्स यूजलेस. तो थैंक यू वेरी मच for everyone for coming, making this a success. I hope it was a success, और I hope you enjoyed. और अगर हमसे कुछ भी, this was our efforts हमेशा कम भी रह जाती हैं जितनी भी आप कर लें. तो अगर हमसे कुछ भी there is shortcoming in our organization, तो we humbly request कि उसको ignore करें, और let's move forward for betterment of nuclear medicine in Pakistan. Thank you so much.